I'd like to welcome everybody to today's webinar presentation. I hope everyone is staying safe, staying home, and staying healthy during these times. I am Michael Saltzman, and I'm the Director of Digital Products at Blue Sky Bio. We are continuing our viral dental education webinar series. We are offering, obviously, the webinar series now, and Dr. Cory Glenn will be presenting again tomorrow, so we have a double there. And tomorrow morning, Dr. Robert Mickley will be presenting as well. So there's the presentation now and 2 tomorrow. So if you haven't yet registered for those, check out the webinars 2020 page. The URL is blueskyplan.com/webinars 2020. And from there, there's also a link to recorded webinars. So if you missed any of those online educational presentations, then you could go there. You can watch the recordings and you can get the CE credit. Just complete the 10-question multiple choice test next to every recording, and we could send you the CE credit. If you're watching the presentation live, then there's no need to do anything. We'll be sending you via email the CE credit directly into your inbox. As usual, if you have any questions during the webinar presentation, please enter them into the questions and answers box, and Cory will be able to address them during the presentation. Before we get started with the actual presentation, Cory, can you give us a little bit of an idea how you've been spending your time over the past few weeks during this whole situation, and how you've been, what's your take on it, how you've been dealing with it?
Yeah, it's been an interesting time. Probably like most people, I initially didn't take this very seriously, and then started listening to a few things that painted a really bad picture that got me extremely worried. And now I've kind of made the switch again. I know it's a very serious thing, but I'm personally ready for the world to get back to normal with precautions and try to keep us from tanking our entire world economy. So. What have I been doing? I've pretty much been doing the same thing, just working on online courses, trying to do some development stuff and looking out for new products. Been making a few STLs to sell, a couple of them I'll show today, but yeah, that's pretty much what I've been doing. Being that my job is an online job, it doesn't change a whole lot when the world goes to hell in a handbasket. So it's pretty much been business as usual for me.
Okay, I mean, your online courses, obviously, your live courses obviously have not been happening.
Right.
We will be publicizing some more in-depth, in detail online courses that Cory is going to be giving. Those are going to be longer, more detailed, but they will be paid courses. So you'll be able to watch them from home, interact directly with Cory, ask him questions, see him face to face. And there will be the hands-on option as well that you'll be able to watch during the course. So we'll be publicizing those shortly. Today, Cory is going to be presenting on the topic of template-driven composite rehabilitations. I don't think Cory needs much of an introduction, but for those of you who might not be familiar with him yet, he started out kind of as the dental MacGyver, practicing and creating ways of delivering high-quality, affordable dentistry. And he has become, over the years, an educator, international speaker, runs a training center in his hometown, which hopefully he'll be able to get back up running in the near future. And of course, he plays a very integral part of the Blue Sky Bio team, clinical team, both on the digital side and the physical part side as well. And, I think Cory is one of the people that are actually very involved with shaping the future of dentistry. So without further ado, I'm going to pass this over to Cory.
All right. Thank you very much. Tell you what, let me make sure that my screen is shared. All right, are you able to see that?
Yep, you can see the PowerPoint.
Great. And still able to now that I've gone full screen?
Yep, perfect.
All right, great. Okay, so like Michael said, I've been teaching for quite a while now, and so I've, for the last probably 5 years, been mostly focused on implants, guided surgery, all of that kind of thing, purely digital stuff. So kind of was glad to, excuse me, kind of was glad to be able to break out some of my my old slides and cover a different topic for once. So what I thought I would cover, since there's not a lot of information out there about it, is these template-driven composite full mouth rehabs. So we'll go ahead and just jump right into it. I think this is a really timely topic, simply because of the COVID-19 pandemic, right? This is going to drastically change how all of us do business. What kind of work is going to be predominant in our practices. I would not want to be right now the guy that only does $80,000 full mouth rehabs and implant cases, because chances are there's not going to be a lot of people to do those things or with the money to do those things in the near future. And so just kind of to start this, I would ask the question, Michael, are you able to see my picture up here? It looks like it's sitting over my slides. Is that better?
Yeah, we see a
Okay.
live video stream of you, and we also see the slide. But yeah, maybe
Okay, great.
move
All right.
the stream a little bit higher so that it doesn't block the slide.
Okay. Yeah, I got it all fixed now. So the starting question would be, how many of your patients need comprehensive dental treatment? So when I'm saying comprehensive, I'm meaning like 6 units or more, perhaps opening their bite, perhaps, just doing major aesthetic work if they've got significant wear. I don't know about you, but the answer in my practice, where I had a majority middle-aged and older patients, was that a vast amount of them really needed this comprehensive work. They're destroying their teeth, whether it's from bruxism or parafunctional habits and things like that. The problem was that very few people could afford it. Okay. So the next question is, okay, when we get back from this COVID-19 things, you're going to have a load of patients that need this treatment if your practice was anything like mine was. But how many of them can actually afford it in this post-COVID world? People have been furloughed. Tons of people have lost their jobs. Their savings have taken a hit. Their retirement has taken a hit. And so again, I wouldn't want to be focused entirely on just these big, huge cases, because who knows when that's going to return. But people are always going to want their teeth to look good. Howard Fran always gives the illustration that if he goes into any dental school that he speaks at and asks a fourth-year dental student, they may be coming out of school with $400,000 of school debt. They're going to have to spend another $1 million to open a practice. And he'll ask one of the female students, how much money would it take for you to allow me to pull your front tooth and never replace it? And so, I mean, if you're a guy, especially if you don't care what you look like, you'd probably do it just to pay off your loans. But for most people, they say there's no amount of money I would do that for, right? Because you care what you look like. And so there's still the demand for this stuff, but we're going to have to get a little more creative in how we go about providing those treatments to those people. And so I think this is a technique that you might end up learning to use quite a bit in the next few years. And the good news is that once you've done a few of these, and especially if you'll spend the time to practice, maybe on a Typodon or something, you can actually get these to where they're pretty efficient, and you're only spending a few hours of time to do an entire full mouth rehab. So that's a really big deal. We'll go through the advantages and disadvantages. But basically, in my practice, I was in a small rural town. We were a PPO insurance-based practice. I had done my residency and learned all this fancy full mouth treatment and stuff, but then figured out really quickly when I got to Winchester, Tennessee, that no one could afford it. And so the COVID pandemic has kind of been a big equalizer. Now you'll all get to practice as if you lived in Winchester, Tennessee. So that's been the driving force really of my career, and how I've tried to come up with creative ways was simply to be able to offer more treatment to my patients. I wanted to do the work, they wanted the work, but we had to figure out ways to compromise and come up with different methods to actually carry that out. And so, if only there was a way that we could restore people's dentition and fix their aesthetic issues and open their bite and do all of those things I was talking about in only a few appointments. Well, it turns out that we do have that. We've had that solution all along. It's just that very few of us have been using it. And so a few of the advantages in using composite resin for full mouth rehab, or at least extensive comprehensive work, is that composite's readily available. It's relatively cheap. It's aesthetic if you obviously do a good job of placing it and polishing it. It's repairable. So, you know, if your patient breaks a crown, there's not really much fixing that crown. But if it's a composite restoration, you know, you add the bonding agent, just apply the composite back to it, and you can fix that. It's fewer appointments. So if we were to do a full mouth rehab and, you know, make them the same shape and contour and everything, but do one with crown and bridge and the other with composite, in my opinion, it's far fewer appointments and much quicker to do that restoration or that rehab in composite. So you'll have less time involved. You're not going to have the lab bills that are associated, other than perhaps a wax up if you opt to delegate that out. It's easy to apply. It's a material you're familiar with already. It's immediate results, and patients love that. You know, if you can show them, you know, excuse me, they walk in to the appointment and then they leave 2 hours later with an entirely rehabbed mouth, that's a huge, huge practice builder. And then finally, it's minimal to no tooth reduction. So oftentimes, unless they've got a tooth that's maybe sticking out too far facial or hanging down too far, most composite rehab cases are going to be additive. And so we're not going to have to do any significant reduction of the teeth. It's going to be far less aggressive. Now, there are challenges with this. So I'll be very frank about it. It is technique sensitive. I've had patients come through my practice that have undergone, you know, kind of like this treatment before, and it was disastrous. You know, it was evident that they didn't do good isolation. Things are chipping and breaking off. You know, it was just not done well. So it is technique sensitive, and that's why I'm giving this webinar. I'm hoping to give you some techniques that will make this a little easier for you. They are going to be more maintenance. You know, if you've got a patient in a crown, other than if they break that crown or just wear it over years and years, there's not a whole lot to do other than just routine cleaning, right? But with the composites, over time, they will lose their gloss and you'll have to touch them up. You know, there's just a little bit more maintenance with these things. So that's something you need to make your patient aware of when they go into this. It's not always going to look as good as it does on the day they leave your office with it brand new. It may not last as long as crowns, and I put may in italics there because, you know, I've done enough of these that I've gotten to see them over recalls, and they generally do hold up really, really well. In my experience, I didn't experience a lot of chipping, things like that. What I would see is that they would tend to just wear the composite more. Okay. Again, not a huge deal because, you know, if the patient understands that and expects it, that's easy to fix or to completely redo at some point down the line. Another disadvantage, you know, it does require meticulous isolation. If there's any place where this whole thing can go south is if you don't have good isolation. And so I'll talk about a few ways to address that. Some people consider it to be lower quality treatment. Again, perhaps it is, but it's also far more affordable and it gets the job done and it does work. And, you know, if you'll approach this correctly, these things should hold up really well in the long term. Maybe they don't look like an $800 veneer that was done by a master ceramist, but you can get darn close depending on how much effort you want to put into it. And then finally, probably the biggest reason I see people not doing this is that it's completely dependent on that clinician themselves. The results they get are going to be completely dependent on them. You could be a pretty ham-fisted operator and go in and do terrible preps and, you know, not do a good job with a crown and bridge rehab. But if you've got a great lab, they can end up making you look like a rock star. And though there may be other problems, what the patient sees in the end result looks really nice, right? The lab can make you look great. You don't have that necessarily here. And so you really got to be on your game. Again, this will take practice. And, you know, once you get the methods, I think you can give results that are pretty close to what your lab could give you with a crown and bridge rehab. Okay. Again, you will need some practice on this. So you need a typodont. I would suggest doing a few of these on a typodont just to practice the entire workflow. And then practice just the techniques of manipulating the composite, figuring out how much to put in there so you don't have tons of flash and cleanup. And so hopefully you still have your old typodont. I've still got mine. The problem for mine is I can't get the teeth anymore. And so that kind of spurred me to start this little project. This has been one of my COVID projects is I actually took an intraoral scan of my own dentition and then turned that into a typodont. And so what I've done is created these teeth where They'll index into the typodont like sockets. And so this is just a 3D printable file. I don't have it available online for purchase yet, but I will very shortly. So if you would like to get a hold of this, it's not going to be that expensive. If you want to get a hold of one of these, it's just going to be a download of the STL files, and then you can print the typodont, and you can reprint as many teeth as you want. So, you know, it's an initial investment, and then 3D printing resin is very cheap, and you can go through as many teeth as you want. So hopefully that'll be helpful to you. Just email me if you're interested in getting a hold of that, and I'll put you in my little tickler file so that when this is up and ready, I'll let you know. Just a couple of shout outs. These are some people who their content has been really helpful to me in regards to composite resin. I would suggest you go take any of their courses, look up their online content, their Dental Town courses, their YouTube videos, all that stuff. But Jason Smithson, Corky Wilhite, and Dr. Terry Shaw. Terry is mostly on Dental Town, but he does some incredible composite full mouth rehabs. And he's kind of interesting in that he does them all freehand. So if you'd like to see maybe a different approach to how I do it, Terry is a great person to check out his content on Dental Town. And it's pretty impressive what he does. And as far as seeing the longevity of these things, Terry has farther back recalls than anyone I know. He can show cases that he did 15 years ago and what they look like now, how they've held up, what additional work he's done. So check these guys out. Just another quick disclaimer, the principles and the knowledge required to do a full mouth rehab don't change just because you're using composite. And so you really need to still be on your game and make sure that you've got the adequate knowledge to start doing this kind of treatment before you just jump in, okay? Even though we are using composite and it's a lot less invasive, it's not exactly easy to get this stuff off. So I wouldn't exactly call it reversible. So do make sure you know what you're doing as far as just the general principles of full mouth rehab. You know, the aesthetic guidelines, opening the bite, figuring out the joint position, all of those things I'm not going to necessarily cover in this, but there's some great content out there that does. If you're looking to learn more just about full mouth rehab in general, not necessarily composite or crown and bridge, but just in general, these are some of the people that have been really helpful to me. Frank Spear, the Spear Institute, Spear Online is a great resource. Dr. John Coyce, Stephen Phelan, Pankey Institute, Dr. Lane Ochi, Mike Melkers, Dr. John Nasty. And then I've got actually a Dental Town course that you can get online on full mouth rehab where I try to simplify some of this stuff. So that's kind of the starting point of maybe some base knowledge that you might want to look into before you tackle one of these cases. All right, so what are you going to need if you're going to tackle one of these? You're going to need basically all the same things that you would need for a full mouth rehab, right? So you're going to need to go ahead and get models, and I'm going to specify that those need to be in centric relation. And the important thing to me is that they also be at the intended vertical dimension that I want to restore them at. Okay, you could absolutely take on a collapsed bite, you could just take models in occlusion, but then you're going to have to use either an articulator or a virtual articulator to open them. And who knows if they're going to be in that exact same position clinically. So I really suggest taking your models and your bite at the intended vertical where you're going to restore them. And I'll give you some guidelines of how to know what that vertical dimension is. And these models can be stone or digital. For your centric bite, a lot of people struggle with getting patients in centric. You know, I went through Pankey Institute and they taught you the bimanual manipulation of the jaw. I never could figure that out. It was really frustrating to me. I think it's wizardry or sorcery or something that people do that. So since I never could make that work, I started learning how to use the leaf gauge. For me, that was far easier, and it gave me a very, very good centric bite. So if you don't know what a leaf gauge is, these things are available online. You can get them from Great Lakes Ortho, any number of dental companies. You can even get them on Amazon, as you can see right here, 25 bucks. But this is a tool every dentist should have, probably a few of them. And the way that these things work is they're just a bunch of little mylar plastic shims on a central pivot. And so you can put as many of those shims in as you want. You can take a few out. But they're great because what you can do is just create whatever amount of opening. You can add enough sleeves between there that it opens them to the bite they want. And you want to make sure that you add enough that it completely discludes all of the posterior teeth. Your proprioception and everything, if you're trying to take a centric bite and then a posterior tooth hits, your brain's going to take over and they're going to go into that acquired bite. And so we would like to remove the influence of those posterior teeth when we're trying to get that centric bite. The leaf gauge does that very well. If you look at this picture on the bottom right, you see that essentially what it does is create a tripod. So the only points of contact are right there on the central incisors. And then the only thing else touching is up here at their joints. You know, their joints are going to be fully seated up into the fossa. You don't want to have them bite excessively hard on this, because if they do, since this is flexible, they'll end up retruding their jaw. And so the way I do this with patients is I first decide how many leaves. I make sure they're discluded in the back. I might even leave the room for 5 or 10 minutes and just have them slide around on it, or just periodically bite and squeeze, then relax. But I want those teeth out of contact. And that's somewhat of a deprogramming mechanism. You get them deprogrammed, then they get eccentric. So I'll come back in the room and I'll say, okay, we're going to take the bite now. And, you know, practice with them. I don't want you to bite, you know, forward. I don't want you to retrude your jaw. I don't want you to squeeze super hard. What I want you to do is just close into a nice, comfortable relationship. And then I'll tell them, all right, slide your jaw forward, slide your jaw back, and just gently squeeze. So that's kind of my verbiage I would do when I would walk patients through this. And it should be repeatable. So you get them in that position, squirt the material between their back teeth, and that's your centric bite, okay? But how do you know they're in centric? Well, it should be repeatable, because centric is where they're going to be fully seated up here in the fossa. The condyles are going to be fully seated, and they're not going to go into an acquired bite or anything. And so it should just be their skeletal anatomy guiding them in and out of this. So after your material sets up for your bite registration, have them open up again, okay? And then say, all right, go ahead and just close in again, and hopefully they drop right back into it. It should be repeatable. All right, if they struggle to get back in there, chances are they went into some funny position when they were first doing this, and you might want to take another. So once I have it opened up enough, I've got them in centric and it's repeatable, that's the bite I want. And I'll either you know, mount models in that vertical, or I will take a buccal bite with my intraoral scanner of that vertical dimension, and that will relate the upper and lower digital models into that opened VDO. You got to have pictures. I can't stress this enough. They don't necessarily have to be the fanciest pictures, but they need to be clear. They need to have the teeth in good focus. And I would, at a minimum, want to get from about right here, just above the eyebrows, down to the chin, okay? That's gonna help a lot with aligning their smile, trying to figure out the midline and where you would like to add things to. So my typical photo setup, if I was gonna do this, would be a DSLR camera, a ring flash. I had a white door in my practice. We just stand patients up against that. We'd take pictures, and I'm looking for a full face at repose, a full face with a smile, an E smile. So E, you know, where they basically are cheesing real big. I want to get a lateral view, and then I want a lateral view smiling. And then optionally, you can also do retracted shots. And I find this to be pretty useful if you're going to do any digital smile design. Put the little Columbia wire retractors in and have them close down, but take a full face picture with their teeth retracted. That way you can see the full dentition. If you need to stitch in STL models, it'll be very easy to do that because you can see all the teeth. And then I'll get another one zoomed in really close to that. Okay, so those are the pictures that I'm going to take. As far as instruments you're going to need, these are a few of the ones I like. I'm sure there's a zillion others that will work well. This is the Contact Easy Strip. And so these can be used for interproximal smoothing. They can also be used as a saw if you've got like a contact that's bonded together. The one I used the most was this orange one because it does have a serrated edge for cutting. And then it's also got diamond impregnated strips on the sides where it will actually smooth contacts. Sometimes if you've got a really badly bonded together contact, you won't be able to get through it with this. You'll end up warping it. That's where it's nice to have a Ceres saw. This is available from Denmat. And so look into the Ceres saw. I think that's a critical piece of equipment for doing these. You're going to need your normal stuff, your composite, your brushes. So I would suggest getting some of these maybe larger bonding agent brushes because those are really useful for dabbing at the composite. helping you to shape it. And those the little bristles on there will prevent you from having the pullback that you would normally experience if you were dabbing at composite with, say, a metal instrument. Okay. As far as the instruments I manipulate the composite with, I always tried to keep a really minimal setup. And so there's pretty much two main instruments I would do composite work with. They were available from Cosmodent, and I used the IPCL long. So it's a thin bladed instruments. These are all titanium nitride coated. And then I also used their multi-use packer. And between those two tools, that's all I needed for composite. It was a really basic setup, and we didn't need a whole cassette worth of stuff to do composite restorations. You'll need your polishing stuff. So you've probably all got your preferred methods of polishing. If you got one that works great for you, go with it. That'll work fine with everything we're going to talk about. The ones I personally liked the most were the Flexi cups and points from Cosmodent. And by the way, I don't have any association, and I'm not getting paid by anybody, unfortunately. So if I'm saying I like a product, it's just because that's what I used. However, I'm very open to accepting money from anyone if they want to throw some at me. So the other thing I liked was the Flexi discs from Cosmodent. These were really nice for shaping facial surfaces of teeth, for rounding out line angles, things like that. And you can get these to a super high gloss shine between those two products. You'll need some interproximal strips. Again, the Contact Easy may cut it for you, but I like to also use some of those metal strips that have the diamond impregnated on them. And I find the ones that have the the perforations in them tend to work a little more aggressively. So you might look into getting some of those. And then finally, the greater curve band. This is something I still find a lot of people don't know about. I learned about it way back in the day on Dental Town. And man, it is one of those tools I just simply would not have practiced without. It was such a great solution to so many of the common problems that we face every day. And I'll show a few cases with that and how I use those. I would suggest also using Caries Dye. So back to one of the ways that you can really screw this up is if you don't get all, and I mean every last bit of all the biologic material off the teeth, then you're not going to be able to have this thing hold up very long. I don't know exactly what the bonding strength is of composite to plaque, but I don't think it's real high. And so you need to get that plaque off. And quite frankly, you're just not going to see it unless you have some way of staining that plaque. Caries dye will stain both plaque or caries. And so that's what I tended to use. But this is a great example. This was a shot from a just simple class 2 filling. But, all the time we see right here at this vertical edge of the box, leakage, staining. Why is that? Well, I believe it's because most people are not getting all of that materia alba, the plaque and everything off the teeth. So if you can see it, you'll be able to get it off. You could use air abrasion. There's plenty of cups and points and pumice that you could use. I'll throw another one out there. This is called Clean and Boost. This was another part of my armamentarium that I used for every single composite restoration that we did in the practice. It's available from Apex Dental, and it's a dentin and enamel cleanser. And so it has a little brushy tip. You squirt a little bit out and you just scrub on it. And this stuff is great at removing any kind of biologic material from the tooth. But the added benefit of it is that it is acidic. I don't remember exactly what the chemistry is here, what that material is. But if you brush this thing around and allow it to sit for 15, 20 seconds, it's going to etch pretty much as effectively as a phosphoric acid etch. And so this is actually what we used in a single step to clean our preps and all the tooth that we're working on while simultaneously etching it. And so if you were to use this prior to your one-step bonding agent, you'll see a big increase in the bond strength, plus you won't get those stain margins and everything. So I clean all the teeth with that. Again, these are those top finisher cups. I use those a lot. The Flexi discs. These were the primary diamonds I used. So, prep with whatever you're comfortable with, but for adjusting the occlusion, for shaping the restoration, these were the two main burrs that I used. It was an egg-shaped, very fine diamond, and then the pointed cone diamond from from Microcopy. These are their Neo diamonds, and they are single use, but in my experience, they hold up really, really well long term, and you can get a lot more uses out of these if you clean them, sterilize them, and all that. You know, they're not cutting the prep. These are doing a minimal amount of cutting, and so they don't wear out all that fast. And these were those instruments, and I've added one other here that I forgot to mention earlier is the Ash Explorer. So whenever I'm doing a posterior filling and I need to create anatomy in the occlusal surface, I do that with this Ash Explorer. It's something I learned from Jason Smithson. It's an excellent technique. I would suggest looking up anything he's got on this. I've got a video on actually how I would place class 2 fillings, but you can get so much finer anatomy with your Ash Explorer than you will be able to with any of your other composite instruments. Okay, so I would add that to your cassette. And then here's that Carry Impact, the multi-purpose tool from Cosmodent, and that IPCL instrument. And then finally, there'll be some circumstances where you might need to use the, where you might have to do a class 2 prep and restore it. So sectional matrices to me are a far superior option to say a Tofflemeyer band. The ones that I liked the most when I was in practice was ultra dense V3 rings. And they work with the wave wedges. These wedges are an important component to that because they're flexible. They really compress outward and keep that matrix tight against the tooth at the bottom of your box. But they've also got this hollowed underside where you can actually slide it up and over the papilla, so you don't end up with tons of bleeding like I tended to if I used a wood wedge. These are not used to separate, they're used to maintain the tightness of your sectional matrix against the tooth. The separation is coming from the ring. So I think if you are using Tofflemeyers currently, you really ought to try this. I think you'll be very pleased with it once you get past the learning curve, and the results will be a much superior result. And finally, you're going to need some kind of illumination and magnification. Again, things I couldn't practice without. If my loop light went out when I was in practice, we were going home for the day. It was so bad, and I had to go home a few times during the day because I just felt like I couldn't see anything after I got used to using this. So if you don't have a loop light or some kind of a headlamp, the Lumadent is the one that I would recommend. They're very affordable. They're very bright. The customer service is amazing. Don over at Lumadent has been extremely helpful anytime I've ever had a problem with a cord shorting out or anything. But use some kind of magnification and use some light. And you'll probably want to get an orange filter on that light as well if you're going to be doing composite restoration, so you don't set it up prematurely. And then finally, the the isolation aspect. Again, if you don't do good isolation on these, they're going to fail, plain and simple. So there's several good ways of isolating. You could use the IsoLite. I think that's an excellent tool. I think you're going to see a lot more of this being used once we all get back to work after the COVID, because as we know, the aerosol is very problematic, with the spread of this disease. So trying to control that aerosol is really important. The IsoLite does an amazing job at it. It's a mouth prop. Depending on which model you get, it's got an integrated light that illuminates the whole mouth. Me personally, since I've got a loop light, I've never used the lighted version of these. I just bought the cheaper one and then used the IsoLite mouthpieces to suction and to maintain a dry field. And if you're a little cheap like I am, then you might look into this product. This is called the Kona Adapter. This was made by a guy, I think his name is Mark Kona, who's a hygienist. And he's a little frustrated with the overall cost of these. And so what he did is made an adapter that would accept the IsoLite mouthpieces, but that would just hook into your high vac suction. And so it's much cheaper. These things are pretty inexpensive. They're about $100. So you could buy multiple of them for every one of your rooms. Hygienists love them. So this is a useful tool. And then we can't ignore the old standard, the rubber dam. I know a lot of people hate the rubber dam, but I'm convinced that that's because they've never gone through the learning curve of learning to use it and become proficient with it. Once I really put in the effort to learn the rubber dam and get proficient at placing it and how to use it, And that used to be pretty hard. You know, now you can watch a zillion YouTube videos that will show you every trick in the book. But I promise you, if you'll start using the rubber dam, you won't want to go backwards. They're so useful. The clamps that, I'm sorry, I'll get to that in a second. You know, back to the rubber dam, you know, this is another thing that's going to become much more commonplace in the post-COVID dental practice, because again, we need to control that aerosol. So this is protecting you just as much as it is the patient and improving the quality of your restoration. And plus it just, you know, it's going to eliminate the patient closing continuously, or you might have the chatty patient that you can't get any work done. You know, that it eliminates all that. It basically takes you back to like you're working in dental school on a typodont, because everything is pristine. You can see well. You don't have the tongue or the cheeks to mess with. So look into the rubber dam. I think it's worth revisiting if you've kind of sworn it off. And you can see, even doing really deep preps, I mean, this is kind of those apple core caries that go all the way around the tooth. There's still ways to isolate with the rubber dam and be able to have full access to that. And so this is so much easier to restore, in my opinion, than if I've got saliva going everywhere and patients closing down and all that kind of stuff. Inevitably, if I'm trying to do it without rubber dam or an isolite, I find myself hurrying because patient is wanting to get past this. They're tired of the suction in their mouth, and I just don't get as good results. So the rubber dam, I think, is great. This is just a case doing that. Again, I was just trying to show here that even really tough caries can be done with the rubber dam. Look into it, it works great, and it will elevate the quality of your work. These are the main clamps that I used. So I had the WOO. These are Hugh Freedy clamps, and you'll find different clinicians have different preferences. Look up all the rubber dam videos on YouTube because they're really useful. I was even referring to some of them today. But I would use this for anterior teeth. I would use this for small premolars. The W8A is what I would use on most molars. Now, if they've got a tooth that's not very thoroughly erupted, it might pinch their gums. And so there's another version of this. I don't remember the name, but it doesn't have the downward turn tines. It's just more of a flat profile. Those are better on those individuals, and it will help you not pinch their gums. The W14A was usually what I used on first and second molars. And then finally, if I was doing anteriors, especially if it was a single tooth isolation case, I would use this number 9 clamp. All right. And then greater curve bands. Again, go get these. These are so great. And man, there's just so many uses for them that I had to, even though this isn't necessarily part of the presentation, I had to throw this in because they're just so useful. So what you're seeing on the bottom is a standard Toffler-Meyer matrix band, and on the top is a greater curve band. So some people will call these a banana band, but you still put them in the Toffler-Meyer matrix the exact same way. Here's the difference with them. On the left, you know, I've applied this from the facial, and on the left, you're seeing a standard Toffler-Meyer band. Well, these things, the tighter you go with them, the more they just collapse in on themselves, okay? So if you're doing an amalgam, big deal, right? It's around a big posterior tooth, that's gonna work great. But I find myself using these greater curve bands the most in the posterior of the mouth. And because they have that big banana shape, when you fold them up, it actually flares the contours outward like this. And so you can tighten this thing down and look how much access you have from the lingual aspect here. So if I prepped a little class 3, I would just throw one of these things on, and it now is just like packing an amalgam. You've got a closed space. You're going to maintain an open contact, but it'll still be a nice and tight contact. And you just squirt the material in, cure it, and you'll just have a tiny bit of flash to address right here once you take this off. So they made class 3s a lot easier. Again, you can see how this is. If you were looking at it from the lingual, you've just got all the access in the world coming in from this side here. The other nice thing about these is because of their shape, again, they're flared like this. So the tighter you go with them, the more that the bottom of that band wants to cinch down around the cervical area of the tooth. So this was an external resorption case. This guy had a lot of resorption. You can actually see there's just a tiny sheet of dentin laying over his nerve right here. And I was restoring this prior to sending him for the endo, and very difficult isolation case. Now, I could have gone in with a laser or a electrosurge and just whacked a ton of this gingiva, but your patient's not going to like you very much on that. With these, I find I'm able to place them and cinch them down to pretty much the bone level, even if I need to, and then just restore it. And now you've got a clean, isolated area that you can put your composite into and contour it, and it just makes life a lot easier. And you can see how close this is to the bone level down here in the spinal x-ray. Other uses for them: diastema closures, composite veneers, things like that. So this was a peg lateral with a big wide open contact. Again, due to the flare of that band, when you put it in, it wants to go out laterally and make contact with its adjacent tooth. And then for a case like this, where I'm primarily working on the facial of the tooth, I would apply it from the lingual, and then I would take a diamond burr and I would just go around the front and reduce this a little bit. So you can still see it's extending up under the gingiva, perfect isolation. Everything's going to be nice and clean. And the way I would restore these is I used a snowplow technique. And so with the snowplow technique, you would figure out your shade and everything, but I would come in here and in that tiny gap, I would apply a thin bead of flowable resin. And the purpose of that is just when you squirt in the paste composite, it's going to push that ahead of it. It's going to eliminate any potential voids that you might get. And when you remove this matrix, you will not be able to feel the transition where it goes from filling the tooth. It's going to be perfectly flush and smooth if you restore them that way. And again, this is, maybe it's not the greatest job in the world with the final result here, but that also probably took 10 minutes. So you can be very efficient with these things and get nice results without having to go through tons and tons of effort like you might with some of the other methods I'll show you. Class 3 and Class 4 restorations. I talked about the Class 3s earlier. Those are super easy. If you've got a Class 4, again, just because of how these things flare, now you've got a closed matrix into which you can pack all this. Once again, I'll snowplow it. And I do tend to overbuild them a little bit. They'll be flash, but again, that's where I'm going to get those micro copy diamonds, and I'm going to just go and reshape that and get rid of any flash after the fact, and then hit it with the polishing points. And then this should attest more than anything how good these things are. This is a nightmare. I hate restoring these things. So patients come in with, in my neck of the woods, there's a drink called Sundrop. It's similar to Mountain Dew, only even sugarier and with more caffeine and more acidic. So we had a lot of people that had these wraparound caries, subgingival. They're a nightmare to restore. And historically, I would restore the facial, and then I'd come back, re-etch, rebond, and then I'd restore the proximals. It was a nightmare. It took forever. With these bands, again, you'll be able to apply them. They'll cinch down. And I love this picture on the upper right. You see how there's blood on the exterior of this, but that thing is cinched down so tightly and so far subgingivally that if you look on the internal of the band, it is just perfectly clean and well isolated. And so you'll be able to shoot your composite material in here and pretty much restore this in one shot. Again, you'll have flash. Just come back and take your diamond. You won't feel the transition down subgingival. You'll basically just be contouring the flash that's up here supragingival. So get yourself some of these. If you ever have difficulties stabilizing the matrix, like on this one, because of how this tooth was out of alignment, the matrix holder didn't want to stay put. Great time to use some of this blockout resin. This is the stuff that they use to create the little wells on the teeth when you're making bleaching trays. I would suggest just buy the cheapest house brand stuff from Patterson, Shine, whoever. And that is a great material to use for securing matrices, bands, all of that kind of stuff. So once you flow this on and cure it, that thing is stuck there and it's not going to come off until you break that off. Okay. Real quick, any questions, Michael, before I go forward and get into the meat here?
Let's take a look. No, we don't have any questions at the moment.
Great. Okay. All right. So the other thing you're going to need, if you're going to do a full mouth rehab, you must have a wax up. This is non-optional unless you're Dr. Terry and can pull this thing off without a wax up. I'm certainly not that good, and most people I know are not that good. And so I would suggest you get a diagnostic wax up with ideal contours and occlusion and guidance and all that. And I would suggest that if you do this for a composite rehab, I would suggest you actually get a digital wax up. And I'll actually show you how you can do that yourself. You don't have to farm that out to the lab. If you do want to send it to a lab, you can do this through Lab Pronto, which we can talk about later. But essentially what they're doing is designing a crown. And Michael, do you remember the crown design fee per unit in Lab Pronto? It's like $8–10 maybe.
Something like that, maybe a little bit more.
Okay, it's somewhere around there. That's certainly a lot cheaper than a physical wax up. Those are generally going to be in the realm of 25 to 50 bucks per unit. And I'll tell you, I'm not knocking that price, because every lab will tell you that even if they're charging probably 50 bucks, it's a loss leader. They're doing it in hopes that they're going to get the full case. All right. So it's a lot of work to do a full wax up on physical models. The digital wax ups are a lot cleaner. You're not going to have to mess with all that. And then you can just 3D print it. And then there's going to be some of the techniques I show you where you really need a printed wax up. Otherwise, you can't do the technique. Just a quick aside, if you are like me and you like doing a little bit of lab work yourself, digital or physical, you can use Blue Sky Plan now to do those wax ups, and it's completely free. As you may know, the denture module, ortho module, surgical guide, there's a pay per case business model on that. But for the crown and bridge module in Blue Sky Plan, it's entirely free. There's no cost associated with it whatsoever. And so you'll be able to do these wax ups and export them, and it won't cost you a dime. It's just going to be your time to do it. And I can do these in a fraction. I would say probably it takes 10% of the time to do a digital wax up for me than it does to do a physical wax up. So this is just a quick video. It's time lapsed. I actually have this on YouTube. If you check out my YouTube channel, which I'll link to later. And I've actually got a full tutorial on how to use it to do wax ups. It's a little different technique than if you were simply designing a restoration. But big picture, what I do is I initially bring my models into the denture module, because the denture module is great for bringing in an entire chain of teeth, getting them globally positioned, maybe stretching them one way or another. And then once I have them in the ballpark, then I switch over to the crown and bridge module, and I'm going to clean up that wax up and make the contours much more precise, and I'll dial in the occlusion. Okay, so I've got tutorials on YouTube of how to do these digital wax ups in Blue Sky Plan. You can do them in ExoCAD, 3Shape, lots of ways to accomplish this. But if you're looking for a free way, Blue Sky Plan is the only one aside from Mesh Mixer that I know of, and Mesh Mixer is not all that user-friendly for doing wax ups. Now, okay, let's say you've done your wax up. One option is you could just go straight to the mouth and start restoring that patient. But I would recommend that before you do that and invest the time, I mean, it may be a 2-hour appointment, right? And then if you get it in there and you don't like what it looks like, you've wasted 2 hours. So, pardon my cough. I don't have COVID, and I don't think you can catch it through the webcam. What I would recommend doing is creating a putty transfer. I did this for any kind of full arch or aesthetic case, and I would let that patient test drive it. And that may be as simple as just wearing it for 10 minutes while they're in the office and looking at it, make sure they like it. But more often than not, what I would do is just have a real short appointment, maybe 5–10 minutes, and I would transfer this into their mouth. And there's not really any cleanup to do on these. And so I would oftentimes just let them leave, go wear it for a week or two. Make sure that, your spouse likes it and your kids like it. They don't think you're talking weird, and that they're not getting joint pain. That's another thing. Remember, this is not easily reversible. So what if you open their bite and you do this big treatment only to find that now they develop joint problems? Well, you're going to have a heck of a time getting that off of the teeth. But Bisacryl, it's not bonded on. It's just locked into the embrasure areas. And so this can be flaked off with no problem whatsoever. So I would let the patient wear this for a while, and I wanted to make sure they liked everything about it before going forward. Okay, and once I knew that they liked everything, that's when we would go forward with actually doing the full composite rehab. Okay. So the way you do these, when you're going to make a putty transfer, you'll have your wax up, whether it's physical or digital. Take some PVS putty or lab putty, and just mix it up, make a hot dog of it, and then just form that onto the teeth and press it down and make a little matrix. Okay, that's what this purple material is. But now the putty is not going to capture all the detail that you need, and you want to get as much detail as is humanly possible here. And so what I would do after that I did the putty is now take some light body PVS and squirt it in here like a reline, and then put it back on there. And that's going to capture every bit of detail that you've got in your wax up, and it'll make it a lot easier. And one other thing I want to point out that's extremely important is notice how I've got this trimmed up here at the gingival margin. I try to trim this and scallop it down into the interproximal area and be within about 1 millimeter of the gingival margin of all those teeth. Because if you don't do that, let's say that it goes way up into their vestibule, you're going to have so much flash to clean off that you may spend an hour just trimming it. You're going to get all in the patient's gums. But if you'll open up the embrasures like this, then when you load this full of bisacryl material and put it on there to lock on, all of the excess is going to flow out of that. And what you'll end up with is just one big solid continuous piece of excess bisacryl here, with nothing at all going beyond the gingival margin of the tooth. So there should be no cleanup to do if you approach it this way. All right, this is our patient, and this is just an example of doing the bisacryl mock-up. So this is him, and then 3 minutes later, I'll load it with bisacryl, I'll put it in there, and then have my assistant hold it for 3 minutes just to let it harden onto the teeth, and it'll be locked on there. And so right after this, a couple minutes later, he can actually look at this, we can critique it, we can see if there's things that need to be changed, because I'd much rather find that out now than once I've spent all that time and effort to do it in the real composite. Okay, so take that for what it's worth. Again, you could do it without all this, but there's more risk associated with it. So this is that bisacryl transfer with no cleanup done. Okay, I've not done any cleanup whatsoever. All of that excess flowed out of those embrasures, and the only flash that I see on this entire thing is a tiny bit between tooth number 6 and 7. Everything else, the margins are absolutely perfect, and it does not need to be touched. So this should be a 5-10 minute appointment, and frankly, your assistant could do it if you wanted to. But once I have this in there, you're always going to have to equilibrate a little bit in the mouth. Okay, so again, we want to get them in centric. How do I equilibrate into centric? I use the leaf gauge. All right, so I'm going to go in and I'm going to put enough leaves in there between their front teeth, and I'll have them do the close down, slide forward, slide back, and gently squeeze, right? Get them in centric. And I'll have some articulating paper between the posterior teeth. So put enough leaves in there that there's no contact in the posterior, and then start removing leaves one by one. Okay, so as you do that, you'll be slightly closing their bite in, and eventually what's going to happen is that they're going to close into that centric, and the articulating paper is going to hang up on one of these teeth. That's where a prematurity is. And so you can just simply take that microcopy diamond, erase that contact. Now they're equilibrated at least to that height, and now you remove another leaf. Repeat the process. And eventually what you'll do is you'll find all these prematurities until you get down to the last leaf, and they should be biting in just that solid, chomp, chomp, chomp with all the teeth hitting perfectly, and you should have their maximum intercuspation at the same position as their centric bite. Okay, so that's how I do that. I'm sure there's other ways. And your patient can wear this for days, weeks. You're trying to evaluate their function, their comfort, their aesthetics. Frankly, it can be worn longer than that if you opt to etch and put some bonding agent on there before locking on the bisacryl. So generally, I don't think that's a great idea unless maybe you're staging a ceramic rehab or something like that. Typically, I'm going to do it for a couple of weeks, but I like to let the patient be my articulator, right? We're gonna dial in centric with the leaf gauge, and then we're going to adjust their excursions, and we're going to get all of that done right, because you'll always be able to do it better in the mouth with the patient's anatomy than you can on an articulator. Okay, so once I've got this dialed in, it's all adjusted, centric's perfect, I'll actually go back in and rescan their arch with that with the intraoral scanner, and reprint that model. And that's going to be my new wax up. Okay, that's the one I will use for doing the composite templates. All right, because that's the one that's adjusted and has the contours exactly how you want them. All right. Again, alternatively, you could just go straight to doing this, but your patient doesn't get a chance to preview it. You don't get to test for function and comfort, and it's not easy to remove. All right, so just buyer beware. All right, so I'm going to get into the actual techniques I'm using. Any questions before I do that?
Yeah, we have a bunch of questions that came in. I can read them out to you. You can also see them in the Q&A in the Zoom.
Yeah, I've got them pulled up here. So can you put the name of the band up again? It's the Greater Curve Band. Okay, if you'll just Google Greater Curve Band, you'll find it. It's I think Denny is the guy's name that owns the company. It's just a very small company, but man, those things are a lifesaver. With Greater Curve, are you using wedges? Generally, no, because these bands are really, really thin. And in my experience, when I put those in there, even though, you know, they've got a certain amount of thickness to them, if I just restore to where the band is, the contacts floss perfectly. They've got just the right amount of pop. So I generally don't find a need to do that. What some people do with Greater Curve bands is they'll actually take a little diamond in there, and where they want their contact to be, they'll just use the diamond and a braid through the band so that you're not wedging teeth apart. You're keeping them in their static position, but building that restoration right to the adjacent tooth. And obviously that gets a great contact as well. But for me, I tended to end up with little areas that would shred the floss when I did that. So I just didn't find a need to use the wedges when I do this. What kind of knife handle and blade do you use to scallop the putty mold? Just a regular old Bard Parker knife with a really sharp, razor-like blade. I'm sure you could use a scalpel blade as well, or any number of things, a razor blade. How would the patient clean the interdental areas? If they're just wearing it for a couple of weeks,
Cory, I think we lost your volume. No, I still can't hear you. Is your headset plugged in? Still can't hear you. Yep. No, we heard you for a second and we lost you again. Is there an issue with your mic?
check. Can you hear me now?
Yep.
Okay.
Yep.
All right. I know the culprit. There's a random button on my headset that should not be there, but that mutes it. So sorry about that. Let me get back to my presentation. And question was, oh yeah, cleaning the interdental areas. So yes, the teeth will be bonded together if you just flash on that Bisacryl. Obviously that is not a solution that works long-term. That's why I don't like to do it for months. But if you're just doing that for a few weeks, I would put the patient on a peroxide rinse, or a very, very dilute bleach water rinse. If you take like a 500 milliliter bottle of water and just put a cap full of that water bottle, just straight up non-concentrated household bleach. I know it sounds crazy, but that's a solution that's been used forever in the perio world. It goes back as far as Civil War. They would use this to irrigate out wounds. It tastes like pool water basically, but you'll be amazed at how good the patient's gingiva looks like that. And I hear President Trump says we can drink it anyway, so it's not a big deal to inject it or whatever you want. So knock yourself out. Yeah, so that's how you would clean it. Can you make your putty matrix on a printed model? Absolutely. You'll see me do that several times here. Do you have the patient lying down or sitting up while using the leaf gauge? I usually have them at about a 45-degree angle. If you lay them all the way back, the muscles and everything are going to retrude their jaw a little bit. And then when they get back up vertical, it's going to tend to, they'll be hitting too much in the anterior. So I typically am going to go at a 45-degree angle when I'm doing this. But as a final step of any equilibration I do, I'm going to get them totally up vertical where their jaws are in this relationship, and I'm going to recheck the bite there. How much time do you make the patient use the leaf gauge for? I don't have a hard and fast rule. It could be as short as 5 minutes. If I feel like they are really being resistant to getting into centric, or I can't get them into a good bite, I might actually make an anterior deprogrammer, something like a Lucia jig, and just have them skate around on that for 30 minutes, an hour. I may send them to go, go to work for a few hours and then come back. But the idea is that you're deprogramming them into centric and getting those posteriors out of occlusion. When you use the digital wax up, how do you polish or eliminate the striations in the wax up? Honestly, I generally just don't bother. There are ways of doing it. You could take some wet resin and paint it on and then air dry it thin out. And that resin will fill in those little peaks and valleys and make it smoother. But remember, you're going to come back after you do all this and do a lot of polishing on it. And so those little striations are going to get polished out anyway. So I don't worry too much about them. How do you get the appropriate amount of opened VDO after you find centric, and how do you record that digitally? Dave, hold on to that question. I think I'm going to make that clear here in just a moment. Missed the first 30 minutes. Will this be on YouTube? Yes, it'll be on there. Okay, this is a good question. Most wax ups are additive, but some areas may not be. Do you adjust the teeth before trying it in? If I'm just doing it as a Bisacryl flash on, no, I'll just tell the patient, listen, you got a wonky tooth here and it's going to be sticking out of this, but understand we're going to take care of that before we do the definitive treatment. They'll still get to see what they need to see. But yes, if I've got one tooth that's way rotated out here, that's, excessively far out, then that will have to be prepped back so that you can cover that in composite. How do you control the orientation of the putty matrix when inserting the matrix for the full arch? Let's jump back here and show you this. When I do these, you can't see the facial of this, but I'm going to take a Sharpie black magic marker, and I'm going to make a big line right here in the between 8 and 9. And I'm also going to make a line on the canines. That just helps me orient myself when I'm looking at it in the mouth. And then, do you have to scallop the lingual of the putty matrix? If you're adding a significant amount to the lingual of the teeth, perhaps, but you're going to need some untouched teeth, okay? Because otherwise, what does your matrix seat against, right? If all your matrix consisted of is the teeth, and you're adding to every single tooth, well, your matrix is just going to go completely down and collapse your vertical. And so either leave some untouched teeth, and if you want to do that, then yes, you can scallop this lingual. But whenever possible, I try to maintain that entire lingual aspect, because that's going to help a ton in orienting this matrix and making sure that you don't add too much. And then, do you use the leaf gauge to capture centric on digital? Yes, I do the same thing. I find it to be just as accurate. Again, I'm going to do the same process, but instead of squirting bite reg in there, I'm just going to grab my intraoral scanner and do my buccal bite. And so it'll be a bite with the teeth open, but again, that's what we want. We want to capture them at the intended vertical. Do we prepare teeth totally as if we were preparing for a final restoration? Definitely not, unless there is a portion of tooth that sticks out too far. You would adjust then, but everything else I'm going to be talking about is mostly additive. All right, so I think that's questions for right now. I'll try to stop periodically and do those. Here is that. Okay, so let's go into the different techniques available. So the first one is one that's been around forever. It's called the palatal shelf technique. The good things about it is that this is probably the best technique if you're trying to go real fancy and add color characterization and maybe dent and shade composite and then enamel and all that kind of stuff. It's really one of the only ways I know to do that well, because what it does is creates a shelf on the palatal aspect that now you can stack all those colors and layers into. You're going to get perfect lingual anatomy when you use this because it's being completely stent driven. It's really easy with this technique to keep the contacts open as well, because you can actually go in there while the composite is still soft and uncured. You can take that long, thin IPCL instrument and cut through there and make sure that there's no composite that's touching the adjacent tooth. And then once you're done with the palatal matrix and you have that shelf, you'll be able to use just a standard Mylar pull-through technique to create contact, or you could use a greater curve band. And then this is also most similar to the traditional techniques. The cons to this is that you got to be on your game as far as freehanding the composite and manipulating that, because all of your facial anatomy is going to have to be done freehand. And I do find it to be slower. If I was doing a full mouth rehab just with this technique, I'd be there a long time. It'd take me a while, but it's got its place. So let's show this. This is just a one tooth case. All right. So if you're going to do this as a full mouth, just expand this out to include more teeth. But we've got a patient who's broken their tooth off, big class 4 fracture here. And we're going to pick the shade. And I generally am going to go in there. You see all the plaque and stuff. You got to get that off. Use your Caries Dye to find that, get it all off. Use your interproximal strips or whatever you got to do, the clean and boost. I'm typically going to create a little bit of a beveled edge, or at least roughen up that aprismatic enamel so that I get a better bond to it. And then here's my matrix, all right? And it should go right to the incisal edge, but not beyond it. All right, so this was made on the wax up. If you don't have a wax up, actually what this really is I just did this chair side. And so the patient came in with that fractured. And so I just made a putty matrix directly in the mouth and then used a burr to carve out the negative of what I think that tooth should look like. That's not as precise as if you were to have a true wax up and make the putty on that. So generally you want to try to do it off your wax up. But from there, it'll be the same technique. So first of all, you got to know where to add your composite. Okay, so stick the matrix in, fully seat it, and then take that Ash Explorer that you're going to put in your kit and just go back in there and scratch in the line of where you need to add composite. Okay, that's going to keep you from adding tons and tons of composite over here in areas that it's not needed. All right. So here you can see that area has been scratched in. This is primarily where the composite needs to be. Now I will go ahead and add just a little bit beyond that, maybe a millimeter or two beyond it, but I'm going to thin that out really, really well with a brush because I don't want that to keep my stent from seating completely. All right, so we're loading this up with composite. I really liked the Filtech Supreme Ultra for these. One of the things, I'm not the guy that's going to tell you to use 18 shades of composite plus a dentin plus a body plus an enamel plus a super translucent enamel. I don't have time for all that, and it's no longer profitable at the prices I could charge once you have to do that. So what I liked about them is they had a 2-shade system. So basically you would use their shade tab, you would take the tab and it would tell you use this dentin and use this enamel. And if you do that, it ends up a really nice aesthetic outcome. And you'll see the final when I show this. So I've added the composite here, and prior to taking this to the mouth, I would take that micro brush and I would dab at this and get it really, really smooth, make sure that there's no bubbles, and taper that out to where it's really thin beyond that line where I indicated needing composite. And now our tooth is ready to go. It's been etched. We've used the clean and boost on it. We have placed bonding agent, and now with that loaded stent with composite, I'm going to carry it and index it against the back sides of these teeth. Okay, and in doing that, it's going to create the palatal shelf. That's where the name comes from. Now, before you go and cure this, what you're going to want to do is take a long, thin instrument, such as that IPCL instrument, and drag it through here and make sure that the teeth are not in contact, that there's not any composite touching that adjacent tooth, because otherwise you're going to have to break out the seri saw and it's going to make life a lot more difficult. All right. So with this done, you can push at it, you can shape it, get it to wherever you want it, and then light cure this with the matrix still on. Some people like to use a clear PVS for this because they can cure better through the lingual aspect if you're adding a lot to the lingual. But once you've cured this, you can pretty much take off the matrix and everything's going to be cured. And now it's just going to be restoring the facial, and you'll be doing that aspect freehand. Okay. But it is a lot easier to do freehand once you have the overall shape and incisal edge of this. Okay. So this adjacent tooth, you can see, has a lot of character. I think my pictures might have flipped, but that's okay. You see all of the little white striations in this tooth. That's a pretty difficult aesthetic result to get with composite. And so if I have a case where it's that demanding and I need to do that, then I'm going to use the Filtek Supreme Ultra. I'm going to use the body shade I'm going to use the enamel shade on the lingual to make that thin shelf. And now that I've got this shelf and there's no contact, I can slide in a Mylar. And now I'm going to go in with the body shade, the dentin shade of the composite. Okay. So I've applied that, and then it's rare that I used these tints, but here I did want to match these. And so I put some of this white stain underneath this and just created some splotches. The easiest way I know of applying those is, again, with that Endo Explorer. And you can kind of just drag it around and try to make the same kind of pattern as what their adjacent teeth have. And now all we lack is that final enamel shade. So we had the enamel shade on the back, and then dentin, add some characterization, and now we're going to go back with that same enamel shade on the front. All right, and so you can shape that out. I generally over apply it and then thin it out with a brush. You can use your IPCL. Since that incisal edge is hardened, now you can use it to just carve and cut back the excess. And this is it, ready to start polishing. Everything's cured. And I'm going to start out with those diamonds I mentioned earlier to do the big shaping, get rid of any, obvious overhangs or anything like that. And then we'll switch over to the discs and those flexi points that I talked about earlier. And this was the final result. And, I thought that was a really good result. It blends in nicely. You can see the translucency allows that white to shine through. And so that's the palatal shelf technique in a nutshell. You can get great results with this, but you can imagine that would be time consuming if you do that on, 20 teeth or so. But it is probably the highest quality way to do it. All right, so that's option one. And if we were going to do that on a full arch, same principle, you're just doing it on more teeth. So let's look at this patient. So this guy came to me on an emergency basis, and he is a roofer for a living. If you can't tell, roofers like to hold nails in between their teeth. He was also a big fan of Monster Energy drinks, and so he's just beat these teeth up quite a bit. And this is his dentition. Lots of problems here. And he initially presented to me just wanting to take care of a painful canine, right? So we did some palliative treatment, got him comfortable, and he was thinking he wanted to go the route of a denture, but then he disappeared on me for 6 months, comes back, and he wants to fix his teeth, but he's got a $1,200 budget. Now, even with composite, I can't do a full mouth rehab in $1,200, but we were able to do basically all his extractions, all his endos, and the composite full mouth rehab at a price of, I want to say, $4,000 or so. So drastically cheaper than you would have done with a crown and bridge rehab. And I thought the end result came out pretty good. So he was able to get the money together and make that happen. So once I had treatment acceptance, we've got to get our records. So again, I'm going to get impressions or models if you're doing it digital, right? And you're going to take those at the intended vertical in centric. You need to get your photos. You got to have your photos if you're going to do any kind of smile analysis and know how to wax these teeth up. If you are using physical models, I would suggest a face bow so that you can mount it up properly. And then finally, if I was using a physical models, I would get also a protrusive record because I want to be able to set my articulator to the right eminence angles and all that kind of stuff. If I'm doing this digital, then forget about the face bow, forget about the protrusive record. I'm going to do it all with digital models and the photographs, okay? Now, this is a tool that I find really, really useful, and I'm happy to send it to you. I've got I call it a smile design template in PowerPoint. It's just some very simple basic tools that I use to kind of break down a smile, see where I need to add material to. And so this is your digital face bow, right? Think of it like the equivalent of if you were to mount up some stone models on a semi-adjustable articulator. And all that this consists of, and I'll play you a little video here, is what I'll do is I'll go up here to the view and turn on these grid lines. And then I'm going to just grab a simple shape. And all I'm doing is inserting a vertical line right along one of those grid lines. Okay. I like to make it a color like yellow that's very visible. Then I'm going to make another line that's 90 degrees to that going perpendicular. And then I'll duplicate that line and have another here. So if you've got PowerPoint, you can make this in 10 seconds. It's really easy. But what we'll do beyond that is that we're going to import the picture of the patient. I'm using this guy because of HIPAA concerns. And you're just going to drop the picture in and place it behind those lines. And what I will do is try to align this top vertical line to the flash point in their pupils. So anytime you take a picture of someone and use a flash, it's going to create that little flash point in their pupils. And we want our smile to be parallel to the interpupillary line, right? And so I'm going to come in and make that line, and then that duplicated line, since it's perfectly parallel, I can look at how it relates to the teeth. And I can see, okay, well, he's got a pretty big cant right here because it's pretty deficient relative to the line on the right side versus the left. Okay, so that'll be clearer when I show you some pictures of this. But we can take this now, and I'll even just take a snapshot of that picture and then scale it, crop in and scale it up so I have a really zoomed in view. And this is extremely useful because even though I don't see the whole face here, I do see where his midline of the face is, because we are going to align that right through the bridge of their nose and through the philtrum of their upper lip. And that can translate down and show me where the midline is in relation to the center of their face. Plus I can see this occlusal plane. All right. And this is something I'm happy to send to anyone. If you want this template, just email me. I'm happy to send it to you. There's a few other things in there like these. These are just templates for golden proportions, so you can stick them in there and try to align them on the teeth and maybe get a better idea of how big you want the teeth to be, how well they are aligning to the symmetry of the patient's face. There's also a couple of just rulers in here, and I find those to be extremely useful because you can actually take measurements in the mouth. So as long as I have something that I've taken a picture of that gives me scale in the mouth. So let's say, for example, that I've got a picture of the patient's central incisor and I measure it with the perio probe to be 8 millimeters long. Well, then I'll be able to take this ruler and scale it to where it is also 8 millimeters long. But in doing so, I've created this ruler that now I can put anywhere else in the mouth and tease apart, you know, what the parameters of their smile are. This is just another one of those zoomed in retracted shots, and it had been aligned to the patient's true facial midline. So you can see where his real midline is. And to me, I didn't notice this when I just looked at the patient, but I'll look at this picture and it's very clear to me that there's a cant, right? Look at the distance of this canine tip to the line versus this one. And I can also see much more clearly that everything seems to be sloping towards the patient's left over this direction. Okay, so these are just useful tools that you can figure out just from patient's pictures. Again, if we had measured that patient's central incisor from edge to gingival margin is 9 millimeters, I can take the ruler, stretch it to where it coincides and that 9 millimeter aligns. And now I could, you know, maybe figure out what I want his teeth to be. So we'll talk later, but an ideal central incisor usually is 10 to 11 millimeters. So if I were to measure 10 millimeters from that incisal edge, I can see where the new incisal edge needs to be. I can even pull in one of those little golden proportions templates and stick these in here. So there's lots of cool things you can do. So this is the digital face bow on his full face picture. I've got these glasses on, but the yellow dots here are his pupils. So you can see these are passing equally through his pupils, and I can rotate the picture around until that happens. And then you can see the vertical component is going right through the middle of the bridge of his nose. And then I shoot for going through the middle of their philtrum of their upper lip. Or some people will go through the little piece of the nose there. But you know, if patient's broken their nose, they may be asymmetric. A lot of people have an asymmetric jaw. The most consistent ones that I find for midline of the face are, again, right here. I try to align to that. And then the other one is right here on the bridge of their nose, directly between the eyes. Okay. And then if we take that picture and crop in, we now can see again, where is he deficient? And it's pretty evident he's deficient in a lot of places because he's worn these teeth down so much. You know, in smile design, we generally want the contours of their incisal edges to follow the shape of their lower lip, kind of like this blue line. And as you can see, the red line is tracing out his incisal edges, so we need to fix that. This is his teeth. You can see where I did the palliative treatment on here, but man, they're really, really worn out, probably from all the acid erosion. Here's the lowers, some non-restorable teeth that have to go. And obviously hygiene's a problem, right? And that's something that's going to have to get addressed before you can do a composite rehab. Okay. So let's do some smile analysis on this. So an ideal central incisor is 10 to 11 millimeters. Okay. That's going to be true for the vast majority of adult patients. On the left, what you're seeing is his final result. On the right, you're seeing where we started. And you can see the measurement of our final central incisor. It's right at 10. So how much length do I add? Well, it's pretty simple. You can just go until you have a 10 to 11 millimeter central incisor, and that's going to be right for most people. And the original central incisor only measured 6 millimeters long, right? So we know that we need to add about 4 millimeters to the edge here. And the other measurement that I think is important, and this is more useful for determining vertical dimension of occlusion, like how much do you open them? There's some studies that show that for most people on a class 1 patient, the measurement from CEJ to CEJ is usually going to be 16 to 18 millimeters. All right. Remember, we measured this tooth. We know its distance. And so if we scale this ruler to that, we can measure now from CEJ to CEJ. And his current one is 13 millimeters. So if you don't have a basis from where to start, a good starting point is just to say, okay, well, it maybe should be 16. So I need to open him 3 millimeters, right? Or 5 millimeters. That would be a good starting point. You might end up equilibrating it down a little or even adding to it, but that's a great starting point for you as far as how much do you open them with that leaf gauge. So older case, this was all done on stone models. These are his models mounted up in centric at the intended vertical. And because I'm an idiot, I did my own wax up. And again, I know what this tooth is, but I want it to be 10 millimeters. And so I use the Panadent articulator and the Cois dentofacial analyzer for my face bow. But one of the cool things with that particular articulator is that you've got this waxing table. So once you've mounted up your maxillary cast, you can actually make this mounting table go up and down. And what I'm trying to do is make it to where it's 10 millimeters down to the table from his gingival margin. And so when I start doing this wax up, I know I basically just need to wax his teeth down to the table. Okay, pretty simple. If I'm doing this digital, I'm going to do all of these same things, but I'm going to take a digital approach on them. Okay, so here we are starting the wax up. I found it easier to use composite. I kept my old expired composite for doing wax ups because most dentists are more accustomed to using that than wax. And this becomes now just like setting denture teeth. You know, I mean, dentures are the original full mouth rehab. Think back to how you were trained in dental school. You know, you contoured your rim, you found where their plane of occlusion should be, you found where their incisal edge should be, you found their midline and all that. And then for setting the teeth, right, you probably used that little metal square and you fit it to your rim, and then you just remove some wax and you set that tooth right to the table. Okay, well, this is very similar. We're doing the same thing. We're going to wax down to the table. You can see it starting to take shape here. And before I spent much more time, I wanted to make sure I was on the right track with him. And so he stopped by, and I just made a quick Bisacryl, or I'm sorry, a quick putty transfer, and I just flashed those 6 teeth into his mouth just to see how we're doing. And he was ecstatic. I mean, he loved it. He was ready to just do his anterior 6 teeth, which I explained was not that easy, but this does at least give me some confirmation that we're on the right track. I like the midline. I like the way his smile follows the lower lip a little bit better now. Maybe we could go a bit longer on the incisors, but this is looking pretty good. So he was super excited, and we actually used this as an opportunity to say, okay, so we can make you some teeth that look this way, but what we need from you is you gotta find some religion here on your hygiene. So, just religious brushing, flossing, rinsing. We got to get rid of all that inflammation before we can tackle this, because you don't want bleeding gingiva all over the place when you're trying to do these. So we finished the wax up, and we're going to do the upper and lower. We are not going to restore the posterior teeth because they oftentimes, what I find is if I do premolars forward, patients still function okay, even though the posteriors are not in occlusion like the first and second molars. And oftentimes what will happen over time is that those molars will super erupt back into function. So I've had cases where I intended to maybe just do the anterior 10/10, premolars forward, and then maybe at some date later, we're going to do the posterior teeth behind that. Well, I've had a time or two where the patients disappeared and come back a year or so later, and lo and behold, the posteriors are in function. And so, you don't always have to do every tooth in the arch. Sometimes you can approach it as a shortened dental arch that's going to reduce the occlusal forces. They'll still function good. It's well established in the literature that a shortened dental arch works well. So it's just something you might consider. And before we do the composite rehab, step 1 is going to be to restore any class 5 decay. Okay, so again, if you're trying to, make a beautiful aesthetic composite restoration in the presence of tons of blood, especially if you're trying to use these templates and injection molding and stuff like that, there can't be any moisture or saliva or blood. And this would be bleeding all over the place if I remove that decay. So I opt to do this in 2 phases. I'm going to restore all of the gum line decay on one day, and then we'll come back and do the actual composite rehab on another once hygiene's under control, inflammation's under control, and there's no gum line decay. All right, so he had a lot of it, and you can see like this is his upper left lateral. By the time we remove the decay, it's pretty much just a big shell of enamel, but that tooth is actually still functioning today. It's doing just fine, and it's a 90% composite tooth. Okay, so this can hold up really well. So I didn't put the picture in, but the way I would restore this is I would apply a greater curve band from the lingual. So the Tofflemeyer matrix on the lingual, the band would go subgingival and create my isolation, and then I would just fill it with composite. All right. And now I just have a big blob of a tooth, but it's very clean right here on the gingival margin, so we can deal with this. All right, so the way that we're going to restore is I did the upper and lower differently. The upper arch I did with the palatal shelf technique. And, I didn't do it the cleanest job here ever. I had to do a lot of trimming, but you get the principle. We loaded a ton of composite into the lingual shelf, and I did every other tooth here. You can optionally wrap your teeth that you're not doing in Teflon if you're worried about, bonding teeth together. But I'll do every other tooth. And then once that shelf is cured in there, then you can come back and shape in the facial. I kind of overbuilt it and then shaped it back with my handpiece. And once you've got those teeth done, now you come back and you do the exact same thing to the teeth that you didn't do the first round. So you'll load those with composite, put them in, cure them, and then shape the facial. All right, so we did his anterior 6 teeth with that method, and I thought they turned out pretty nice. Again, it's just replicating that wax up we had done. And you will need to do some polishing. I think we were worn out from this day, so we did some cursory polishing, but there's still some striations and stuff that need to be gotten out. That's where those discs and points are very nice. And for the posterior teeth, I usually go with a different approach. So I'll typically make a clear suck down and then reline that with a clear PVS material. So it's got a very intimate fit, and this is all being done on the wax up. And for the posteriors, I'm just going to load the whole thing where those posterior teeth are that need to be added onto with composite. We're going to etch, bond, clean the teeth, and then I'm just going to squish the thing on and cure right through it. Now, obviously, when you do that, you're going to cure all the teeth together, and that's fine. I know that. The way I address that is that now that this is all bonded on and we've got the tooth to full contour, I'm going to come back in with a small pear-shaped diamond and just cut some little tiny proximal boxes and break the contact. If there's any excess flash, you'll have the access to get that out and to make smooth contours interproximally. And then I just restore them like class 2s. Okay, so here he had a big space. These last 2 teeth we were not restoring. This tooth and these 2 were the only ones that we had to do that way. So we did them all together. But even if you were doing, let's say, you know, from premolars back to all the molars, do it the same way. I'm just going to cut class 2 preps into them and then go back and restore those. All right. And you can see here where I've cut those in. This was what the tooth looked like after I loaded it with composite. And then we went back in, broke the contact here, and then I just restored those with my my Triodent V3 rings, or I think it's Ultradent now, sells them. But we just cut those preps and restored them. You can actually see it's a little difference in the color of composite. I'm not sure why I used a different composite there, but that's a simple solution, okay? And as a quick aside, if you hate doing class 2s, which a lot of dentists that I know do, I used to be the same way. I absolutely despised them. If I saw a quadrant of class 2s on the schedule, I just wanted to go home and cry, until I figured out kind of a system for doing those. And I don't have time to cover it for today, but I've got a course on Dental Town about it. I've got a video on YouTube about it. This is my channel. It's just in Cory Glenn. And this is just, it's not narrated where you can, you know, have me telling you why I'm doing what I'm doing, but I still think you'll get the big idea. But this was a game changer for me. It made class 2 so much easier, and the results were just night and day better. So check that out if you hate class 2s. All right, so that's how we're going to get the posteriors where they're not all bonded together. It's quick and easy. The first step of just bonding them all together is going to be a 5-10 minute process. And then the rest of it's just going to be however long it takes you to do class 2s. And if you got expanded functions, you could pawn it off on them and make them do it. Okay, so option 2, I did his lower arch a little bit differently. And so with this, what I did is I made a PVS matrix, and I actually embedded mylar strips interproximally to maintain open contacts. And so the idea here is that I'm going to use a dual cured composite, and I'm going to just fill this thing up almost like you would do a putty transfer with your Bisacryl, but I'm going to use definitive composite material that's intended for long-term use. And I'm going to use something that's dual cure so that it can cure despite not having any light get to it. All right. So the way I make this is I've got the wax up done. I'm going to take my Serra saw and I'm going to saw through and make some tiny, tiny little spaces interproximally with the teeth. And in between each one of those, you can see I've cut my mylar into little squares. I'm just going to place those in between the teeth. And with those in place, now I'm going to make a putty matrix. All right, so this is light body PVS to capture all the details. And as it's doing that, as you're applying it, it's also locking these mylar sheets into place. And then I'll go back over that with a heavier body or a putty, something of that nature. And so this is the matrix. It's really ugly right now, but you can shape this up and make it where, again, it goes right to the gingival margin. But the way we're going to use this now is that we're just going to fill it up with dual cure composite. The material I used for this case was called Injectafill by Apex Dental. And we're ready to do this appointment too. That was all done in the lab before he showed up. And so here you can see how much that hygiene has improved. Remember that tooth that there was just a tiny shell of enamel left? This is it now. And that tooth is still doing great. So now we're ready to do the bottom. Notice that the gum line decay has all been restored. I don't have to go back and mess with that and create a big bloody mess. We want the gingiva as healthy as possible. Okay, so this was actually one of the learning lessons of how I learned you need to scallop that margin, is because here I did not do it. And do you see all of this flash that I've got? I spent a lot of time having to clean that up with that little pointy diamond cone burr. If you would have scalloped this, you wouldn't have all this cleanup to do. But here, what we did is we took this and we're just going to now adjust it. And there's been no additional composite added to this other than what we just did in the single step. It's not like it was all ragged and I had to go, fill holes and bubbles. It was purely additive, and then the rest of it was all done with finishing burrs. So just go around, open up the flash. That's why you see some bleeding at the margins here, but this is all well bonded on. Okay, so this is how he left that day. His smile is pretty well restored. This kind of looks like caries, but it's not. It's good hard dentin and enamel. And this is it, and just need to do some final polishing. But let's look at the vertical dimension now. We're back up to about 16 millimeters CEJ to CEJ. We opened his bite. We added back to the proper length of his central incisors. We made sure it fit in his face using that smile design template. And so these are just the parameters I use. It's not rocket science. I mean, just follow the way I'm doing that and you'll know where to add the teeth, right? This was his final result. Good result for what he paid, right? Is it as pretty as some, veneers that cost $800 a piece? It's definitely not. And that's one of the downfalls. If you're going to use these template techniques, oftentimes you're going to be doing them in a monochromatic shade. And that's going to mean it's not going to be quite as beautiful as ceramic. You don't have built-in translucencies and all that. But listen, I mean, if you went from here to here, as a patient, you would be ecstatic, especially if you paid 1/10 of what it would cost for the ceramic rehab. Okay, so again, this was a pretty exciting case. Got the result we wanted. Hygiene improved dramatically. We took care of all the disease in his mouth, and we did it for a budget of around $400. All right, let me check out the questions. All right, so when you use a digital wax up, how do you polish and eliminate the layer striations that it captures? I don't. So when I'm using a printed one, as I mentioned earlier, I'm just not going to worry about it because it's all going to get polished at the end and those will polish away. So I just don't worry about it. But if you are worried about it, take some wet resin and put a skim coat on it and then light cure that, and it should make it glassy smooth. Can we find out on the digital model which are the areas of the tooth that need to be adjusted before making the temp crowns? You'll absolutely know that from your digital wax up, because you'll see, like say if you do this in Blue Sky plan, you'll have your blue or green model and your white teeth, and you'll see that tooth shining through. Well, that now is an area that has to be adjusted. And there are ways of going and making a stent so that you can precisely adjust that in a given area. Unless it's a really sticking way far out, I generally wouldn't do that. I would just eyeball it and know here's an area I need to adjust, and I'd make the adjustment. Can we place plumber's tape on the adjacent teeth to keep the gap? Yes, and that's probably a good idea to do. You can still get some excess that will flow over there. And so if you're using the palatal shell, use that skinny instrument and cut away that excess material. If you're using a stent where you're just doing it all in one shot, you're almost inevitably going to bond them together, and you can expect to have to break that contact and maybe just restore it like a class 2, class 3 filling. Can you run through the Kona Adapter process again? So I'm afraid to go too far back in my slides because I'll never get found again, but just look up the Kona Adapter on YouTube. It's a very small little metal piece. It's about 1.5 inches long. And one end has been sized to where it will plug in and adapt to an isolite mouthpiece, but the other end is shaped to where your high-speed suction will go into it, and that just allows you to do the suction as you're working. Frankly, if you have isolite mouthpieces and you have a set of calipers, you can just take these measurements and design one for yourself and 3D print it. I mean, it may be cheaper just to print them and make them single use. That maybe that's a project that I need to do. What app do you use for the digital Facebook? That's just simple PowerPoint, the very basic PowerPoint. It's nothing fancy. I'm happy to send the template if you want it. Just email me. use PowerPoint to do the digital wax up. No, actually I use Blue Sky Plan to do the wax up. I'm using PowerPoint to do the smile analysis. Okay, so that's an important distinction. I'm trying to figure out where the teeth belong using PowerPoint, but wax ups are all getting done for me in Blue Sky Plan nowadays. In this case, why didn't we do some gingivectomy in the upper left to mimic the central? Primarily because if you look at this guy's smile line, I mean, he wouldn't show his gingival margin of a central if he won the lottery. So for me, it would have been nice to make it look cool for retracted pictures for other dentists, but I don't know that practically there would have been any reason to do it. No occlusal box. I'm assuming what you're referring to is when I cut in those boxes. No, I don't do any occlusal extension because remember, I've created the occlusal shape by the template. So the last thing I want to go do is just prep out all my anatomy and now be having to restore a bigger filling and use more material and all that. The idea, if you use the template, is it's already going to be in the right shape. So the only reason we're prepping is to break contact with the adjacents. Hi, Doc. Does the Coist table kit any articulator, or could you give advice on which it works with? I think what you're asking is with the Coist dentofacial analyzer that I use for face bows, will it work on other articulators? It's designed for the Panadent articulator, which is what I use and like. But I did have other articulators and found that if you'll call Panadent, they do sell adapters. So I had I don't remember the brand now, a Danar articulator or something, and they had an adapter that allowed me to use it and transfer everything over onto that articulator as well. So yeah, look into that. Isn't it hard to get the Mylar bands to seat? Good question. In fact, I forgot to mention that. He had relatively loose contacts between, like if you look up here at that upper right picture, you see the gap in between his lower centrals. If they did not have it, you're going to need to take those interproximal strips, and you're not removing a lot of tooth, but you are going to strip them just a tiny bit, enough that Mylar can seat in between the teeth. Okay, so yeah, that's a good point. Appreciate you catching that. Do you recommend an occlusal night guard after treatment? Really, if they're getting extensive treatment, a night guard is always a good idea. So yeah, I would say that's a good plan. What's the email again? It's cglenn@blueskybio.com. How do you coach a patient to chew when their posteriors don't occlude? Well, if you've done it as a shortened dental arch, they will have posteriors occluding. Their premolars will. They're going to have canine guidance. And so if you've never done that, it is a little counterintuitive because you think, how would they chew without their posteriors? But remember, if we've opened them 3 millimeters in the anterior, that's probably 1 millimeter in the posterior. So they're barely discluded, and they just frankly don't notice it. And again, an advantage of doing that is in the early stages of the rehab, by having fewer posterior teeth in a full occlusion, you shut off some of that proprioception and you really minimize how much bite force they can generate. And so it's protective of your restorations as well. So yeah, shortened dental arch, there's tons of lid on it. If you look that up, and again, you could either go back and later restore those posteriors immediately, or you could just give them some time, and oftentimes they'll super erupt. Now, if you got them 4 millimeters apart, forget it, it ain't gonna happen. But if they're relatively close, then that'll work. Can you give a source where I can learn step-by-step smile design in PowerPoint? I know Christian Coachman does a lot of that stuff. I know that Christian Brennis does a lot of that. Marco Tadros. I do some of it, but I haven't put it in the form of a course. So maybe I'm going to have to do that. So I'll try to put something together in that regard. What's the minimum amount of composite required for an anterior incisal edge without worrying about it chipping? I would want a 1.2 millimeter thickness up there, but obviously thicker the better. You don't want to make a huge thick rabbit tooth, but use as much as you can without it looking awkward, because that will add to the overall bulk and keep things from breaking as easily. Have you gone away from using a clear stent with integrated Mylar bands like on the Activa thread? That's one of the options I'll show a little later. So I'm just trying to show you as many options as possible. Try them all on a typodont, see which one you like best, because it'll be different in different operators' hands. Okay, so next case. Now this is an old one. This was 1 year out of dental school, so don't be too hard on me, but this was one of my first efforts at doing a comprehensive case. And man, this case scared me to death at the time. I wouldn't worry about it now, but I looked at this and just thought, oh my gosh, what have I got myself into? So lots of issues. We took some stone models, we did all the pictures and everything, and you can obviously see a bunch of issues. He's got the stepped occlusal plane. So we started using the same parameters to make our wax up. Here again, I'm an idiot and did my own wax ups, which is why it's not very pretty. I can do these a lot better digitally than I could physically. And so with this option, we're still going to do the wax up. We're still going to create a matrix, but here what we're going to use is a copyplast matrix, or you could use any kind of clear suck down pressure form material. Excuse me. But it does need to be transparent, and we're going to do a suck down pressure form. Pressure form is preferable if you've got that option. It will capture much more detail. So something like a mini star or the Ercodent. I had a mini star, that was what I really liked. But we're going to do a suck down on that wax up model. Okay, don't do this if it's a true wax up, because immediately that hot material will hit it and melt it all, and now you're going to have to pay to redo it. So either duplicate it into stone, or preferably just scan it and 3D print that model, and then you can suck down on that. And then what I'm going to do is, you know, we've talked about already, you could just all in one shot, just fill it with composite and jam it on, cure it, and then just go prep out the interproximal. But then you got lots of fillings to do. And if I had, you know, 30 interproximal fillings to do in an afternoon, I'd go jump off a bridge. So what the goal was here was, let's see if there's a way to keep the contacts open. And so what I did was use that copyplast, and I used a scalpel to go in very carefully at the contact and just slice right through it. Okay, and that's going to give me a slot that I can insert a Mylar sheet to keep the contacts open. We're still going to clean, etch, bond the teeth, and you know, isolation is important here. I would suggest using the little mouth retractors to keep their lips and cheeks off of it. Have your assistant really on the ball to keep their tongue off of it, because this is really not a situation where you can use a rubber dam or the ISO-Lite. So make sure that your assistant is wrangling that tongue, and also keep that high volume suction behind, further back in the throat than your operating area. Because, you know, I see some people do fillings and they do it with cotton rolls and stuff. That's not good enough. That's gonna fail. And the reason is because, you know this, if you take a cold mirror and stick it into a patient's mouth, what immediately happens? Well, it just fogs all up. It's got tons of moisture in the mouth. And so you've got to keep that suction back there to keep that moisture from building up on your teeth. Because if you've bonded, you've got bonding agent on there, and then it gets wet, well, the bond is done. It's not going to work from there. So really be careful with your isolation. And what I did in this particular case, you could do whatever you want, but I used a dual cure composite. Again, I believe it was Injectafill. There's several on the market. And then before I cured that, or before I let it dual cure, I'm going to insert those Mylars. So I didn't have a lot of pictures from this case, being that it's so old, but you get the idea, hopefully. We did a few teeth at a time here. I think I did 2 teeth at a time, although frankly, you could have just done them all at once. And this is it immediately after. This whole appointment, I mean, maybe an hour, it wasn't that long. I don't remember exactly what. The downside of the dual cure is they do not shine up as well as a, you know, like a hybrid composite or a microfill composite especially, but it got the job done. And for this particular guy, we were only doing this to stage him. And so we ended up, what I would do in my practice sometimes is people would want a full mouth rehab, but they couldn't tackle it all at once. So I might do one of these template techniques and go ahead and do the rehab in composite, but then put them into the crown a year club or the 2 crowns a year club, and let them gradually convert those over to porcelain. Okay. And that was a good solution. It allowed them to stretch the treatment over time. And here we were prepping one side and we did some crowns. And then eventually we did some implants on the bottom. I believe my surgeon actually placed these because he had to go to sleep for it. And this was the final result. Is it the most beautiful thing in the world? No, I mean, he's obviously been drinking tons of coffee, dentures all stained up. He's still got some diastemas because he didn't want to do ortho, but by and large, this is much, much better than where he started. We've got a cleaner occlusal plane that follows an actual plane. It's not just a roller coaster. And we've got a much better look to the teeth. And so patient was happy. I could definitely do this case better with some of those smile design principles that I didn't understand as well at the time when I did this, but I'm mainly trying to show you just the technique of how to apply that composite quickly. Option 3, I guess maybe I should, is there any questions right now? No. All right, cool. So option 3, this is a technique that I had always had the idea that this would be so cool if you could do it, but there just wasn't a way to accomplish it back in the days when we were using wax and stone models and everything. So this is a purely digital technique. If you're going to follow this one, you've got to do this digital. And so I'm going to give credit to this technique to Dr. Colin Lathrop down in Texas. I forget what name he's given it, but I call it the every other tooth technique. And so what we're going to do here is we're going to still do all the same stuff. We're going to do the smile design, and we're going to do a full wax up. But the cool thing about digital is that I can individually toggle on and off those wax up teeth. And so what I'll do is I'm going to toggle on every other tooth that I waxed up. So this is her original dentition. She's got a missing tooth, and he's going to make a Maryland bridge out of composite. But you can see here, we've turned on this tooth, not this one. Turned on this tooth, not this one. Turned on this tooth. So I'm going to print one model of the wax up with every other tooth, and then I'm going to print a second model that has the entire wax up. All right. And again, digital is the only way I know of accomplishing that. If you know of another way to do it with physical models, I'd love to know. But this is the patient. Here's her pre-op smile. You know, a little ragged on the edges, kind of a up and down occlusal plane. Edges aren't following the lower lip as nicely. And so we're going to try to improve upon this. So we did the digital face bow, and if we zoom in real closely on that, we can see that midline is great. And gingival margins are pretty good, but the incisal positions could definitely use some help, right? So we could lengthen these incisors a bit. We're obviously going to add a tooth here. We need to fix all that wear. And so these are the issues that need to be addressed. I don't usually do this, to be quite honest, but I just throw it in there because it is part of that template that I'll give you if you want it. But these are just teeth with golden proportions, and you can stretch them and kind of just get a rough idea of the contours you're wanting to add. And then if you make that transparent, well, now you can see underneath how much tooth needs to be added, right? So you could use the ruler and all that stuff if you wanted to. So here we are in Blue Sky Plan. So again, Colin lives 11 hours away from me. This is where digital is so great, is because he just simply took the pictures and the intraoral scans, uploaded them to me, and I had them immediately and was able to start doing the wax up. So using all those principles of smile design, I'm going to go ahead and start my wax up. This is being done in Blue Sky Plan. Again, look for my tutorial if you don't know how to do that. And here's the big picture of how I do this. Again, I'm going to take this into the denture module first. I'm going to add the entire chain of teeth. I'm going to scale them where they're roughly the right size and where there's a pretty close alignment to the teeth. And then I'll go over to the crown and bridge module and do the fine tuning. So here you see me doing just the big picture alignment. I'm taking that entire dentition of teeth that we imported, and I'm trying to line it up to these models, and then go to crown and bridge, fine tune it. And then when we finished the wax up, now I could just go over here in the teeth surfaces panel and toggle on or off the teeth that I want. So every other tooth, I just toggle off. And then I'm going to export this and 3D print it. And then I'm going to turn all the teeth on, export that, 3D print that. So we've got two wax ups, one with every other tooth, one with the full thing, okay? And there's a lot of ways you can make these stents. So the way Colin approached this case is he's injection molding it with a flowable type composite. And so this is a clear PVS. There's plenty of manufacturers out there that make this, but it's really helpful because obviously it's clear and you can cure through it. But beyond that, these just PVS tends to be too flexible. So here's what I would suggest you do to make this matrix. let's say you've printed out this wax up model. The way I do this is I'm going to take some aluminum foil and I'm just going to loosely wrap that model. And essentially what that does is we're going to do a suck down on it. It's going to keep that suck down from going into every little nook and cranny in detail, because I want the PVS, the clear PVS, to do that. I'm trying to make just a tray. Okay, so I could do that with suck down. I could print it out of clear resin. We could use triad clear material. Any of those would work, but I like to just wrap some foil on this and do the low-tech method of just using some rigid clear plastic. And it's not going to capture all that much detail. And so once I finish that, I can now reline it with clear PVS, squish it on, and it's now rigid on the outside where it'll maintain its shape, but the inside is going to be soft and it's going to be highly detailed for capturing all of that, the embrasures, and making sure you don't have tons of excess building up interproximally. Okay, so as you might assume, we're going to do every other tooth here, right? So what Colin's going to do is go ahead and etch each tooth that he's planning on doing. Now, the reason he's etched the sides here is because that's where he's going to do the Maryland bridge. And so he's going to just basically create composite, an entirely composite tooth bonded to these adjacent ones. And then again, every other one. And so he's got his stent, he's placing it in the mouth. Me personally, I would prefer if each tooth that I was not restoring got wrapped in Teflon. That's just going to ensure that you're not going to get bonding agent on them and you're not going to prematurely etch them. Just easier to maintain that open contact. And he is putting some Teflon under the pontic here. And the other point to notice is, do you see up on the incisal edges right here, how he has used a probably a number 4 round burr, and he's just punched right through the incisal edge through the stent. And that's going to be his port where he injects the material. Now, again, I never got to clinically do one of these cases, but I did some similar. I also like to go ahead and put one of those ports right up here at the gingival margin of the tooth, because that gives me an escape, right? So as I inject, it's going to fill up, and then when it hits that gingival margin and it's filled the entire mold, it's going to flow out of that, and I know I've done enough, and I can just cure it now. You will have a little button of composite to grind off, but that's not a big deal. And so here you're seeing him, he's injected this tooth remains untouched, other than bonding this pontic to it, right? And so we're just going to do that every other tooth. And then once you complete that, you'll be able to come in with your interproximal strips. You'll be able to smooth up these interproximal contours. And you're not going to have tons of excess flash, like adding up here to an incisal edge on this, because your stent fit all the way against this tooth before it was modified. Okay, so you can polish a little bit if you want right now. I mainly would focus on getting the embrasures and the proximal contacts nice and smooth. And now we're going to take our other stent that was made on the full wax up model, and then just go back and do the same thing, right? So here you see the injection port. The stent's already been removed, but the teeth are covered in Teflon. That's going to maintain this open contact. And he uses, I wish I could remember actually what flowable composite he uses. He might be on here, maybe he can chime in, but I do know another good material for this, if you're trying to use a flowable type resin, is one that is made by Bisco called Reveal. And it's actually one that Ed McLaren recommends using in his bonded aesthetic functional prototype technique. It's a very similar thing to these stent-driven techniques. You might look that up for another method to add to your toolbox. But that's Reveal by Bisco. So here you see the final. And this is after he did all his polishing and trimming and everything. So this was, I think he told me, about a 2-hour case, right? And basically restored her premolars forward and really, really improved the overall aesthetic look of this patient's smile. Okay, let's check for questions. I think I got one more case. No questions, so we're good. All right. This is that Activa injection molding technique that someone referred to earlier. So this was a patient with a severely worn smile, really has beaten his teeth up over the years. I'm going to race through a couple of these, but I'm going to follow all the same principles, right? I know the length I want the teeth to be, so I'm going to raise it up and then just wax down to the table. All right, so that's the opened VDO that we're going to restore him at, right? Remember, use your leaf gauge, take it at a centric bite at the intended vertical. And if you don't know how much to open them, a great starting point is measure CEJ to CEJ, shoot for that 16 to 18 millimeters if they're a class 1 patient. All right, so we're measuring his preoperative central incisor, and this is measuring 10 millimeters. That would be an ideal central incisor. And so you can see we need to add a little bit of length. So I'm going to add 1 millimeter. When I look at a patient like this that has worn their teeth really bad, I try to err towards the low end of adding to their teeth, both in opening their vertical and how much length I'm going to add. Because the more length you give them, the more of a lever arm they're going to have to potentially break that off. Okay, so we're going to just go to the low end and use a 10 millimeter incisor. We set our table to 10 millimeters, and now we're just waxing down to the table. Same principles if you do it digitally. Another useful tip someone taught me was that if you were to take a line and draw straight down through the axial middle of the tooth, then those lines should all point down to that patient's belly button. Okay, so if you're in the midline, like 8 and 9, they're going to be a slight slope like this, but angling down toward the midline or toward the belly button. As you get to the laterals, they're going to have a little bit more angulation down this way, and then your canines are going to have more. Okay, so that's just one of the ways that you can try to make your smile look a little better is for all those teeth to have the right inclinations. They're not sloping one way or another. And the posterior, again, this is like setting denture teeth. It's just setting them down to the table because I've established the vertical I want, I've established the occlusal plane I want, and so I'm just adding material until they touch, right? Canine on the table, central incisor on the table, lateral incisor, 0.5 millimeter off. It's just like dentures. And so we finish the wax up. Again, this wax up is nowhere near as good as what a lab would have done, but one benefit to doing your own wax ups is you sure learn a whole lot when you start doing these things. And they may not look as good, but it's still a useful exercise if you've not ever done it. An important thing to notice with all of these techniques is that whether you're doing it digital or with wax or composite, you need to have a really, really crisp line of where it transitions from composite to tooth, okay? You wanna make sure that that's as clean as possible because if not, you're gonna end up with tons of flash up on the gingival margin. Well, that's not gonna work. So you wanna make sure that basically maybe 1/4 millimeter right here is just their original natural tooth. And that way it provides a seal and it keeps all your material contained within the matrix instead of flowing out all over the place. We did a putty transfer, right? And we cut the notches in there, scalloped it like I mentioned. And this is that Bisacryl mock-up flashed on, all right? We didn't bond it. We were just looking at it and evaluating it. And that looks pretty good to me. And so once we had that, we went ahead and made the matrix. So this is some Essex rigid plastic and sucked down. I did the upper and the lower on the on the wax up models. And then kind of like the earlier option, I'm going to use this curved scalpel blade and I'm going to go right to where the gingiva ends here interproximally, and I'm going to stab into it and drag it right down that crease interproximally, okay? That's going to give me a place to insert those mylar strips, okay? You don't want to go beyond that because, you know, the gingiva is in the way. You won't be able to insert the mylar any farther than that. And what I did is create some injection molding holes here. So I create one on the incisal. I don't know that I really needed to do it from the lingual, but I did. And then I made one up here on the facial. An important note is when you do these, you're inevitably going to have a little bit of flash material like this. So punch those from the inside out. If you're using like a number 4 round burr, punch through from the inside out, and that way you're not going to get little plastic shavings incorporated into your stent. Okay. Now I was playing with the new material at this case. I'd just been up to, gosh, I'm blanking on the company, the company that Pulp Dent that makes Activa. And I'd just been up and visited their factory and they were showing us this cool new material they had. And I thought, man, this case is coming up Monday. I said, hey, would you give me a few tubes of that and let me try it on this? I want to see if it works. And so this is a cool material. It's bioactive. It's very good at helping remineralize tooth. It's very good at helping minimize caries. It's a dual cure composite. So what you can do, and one reason I like it is it comes with this tiny little cannula tip, but it's in a big syringe. So you can apply a lot of material through that little tip. And they kind of describe this as a rubberized resin, so it's better at absorbing shock. And you can theoretically use it with or without bonding agent. It actually does generate a little bond without a bonding agent. However, if you're doing this and you're hoping it to last any length of time, I would suggest use a bonding agent on this. So here's his teeth. Again, the leaf gauge, these are out of order, sorry. And here is the video. And so again, this is on YouTube. If you just look up full mouth composite rehab with Activa and my name, you're gonna find this video. I've talked through some of these, so I'm gonna jump forward. We've got our stent. And again, you're going to have to be able to insert the Mylar both through the stent and between the teeth. So if their contacts are super tight, use a diamond abrasive and go in there and loosen them up just a little. We're not looking to break contact. We're just looking to create enough gap that a Mylar will go in easily. We do that in between all of the teeth, and I'm very careful not to induce any bleeding because again, bleeding is your biggest enemy if you're trying to do this. And we're checking the stent out, and you can see how much additive, how much addition we're doing to the teeth right there. And I'm also going to put the stent on and make sure that I can go all the way through the stent and through the proximal contact, because the last thing you want to do is fill this full of material and then you can't get your thing in. All right, so the stents are in place, teeth have been etched, bonded, cleaned, all of that, we're isolated. And with the stent in place, now we are running those Mylar sheets in between them. Okay, and these are what's going to help maintain the open contacts between them. All right. I'm sorry, actually now we're etching. So this is clean and boost that I talked about earlier. This serves as both a cleaning agent to get all the crud off the teeth and as an etchant. And so we use that. Apply your Bondo, and then you're going to put your stent on, and remember to have your assistant keep that isolation good. I'll jump forward a bit. We're drying it off really well. And now we're going to put the stent on. All right, and with the stent in place and the teeth all primed and ready to bond to, we insert the Mylar strips. This takes forever, so I'm fast forwarding a bit. And then once we've got that, now we're ready to inject the material. Okay, so you can take this little cannula tip and form it to wherever you want and inject from wherever you choose. I generally go from the occlusal port, but you can put a lot of pressure on this gun. And so you see this thing is filling up the teeth, but notice that it's not going over to the adjacent tooth. Now you might have a little bit.
It's not actually playing.
Oh, it's not playing?
No.
How long has it been doing that? Have I been talking here for? Oh gosh, let's see here. Have I literally been talking forever with no video playing? Are you seeing it now?
Click play. It's not playing right this second. It's not playing.
Right. How about now?
Yeah, now it looks like it's loading.
All right. So
yeah, there we go. There we go.
I'm sorry if I was narrating a blank screen there, but again, just go back and review. Everything's been etched and bonded. And then once you've done that, insert your stent, insert your Mylar strips, and then you're ready to begin the injection molding. So I take the Activa, stick the tip in, start injecting until it flows out my overflow holes on the buccal and the lingual. And now you will get a little flash go out in between here, but it shouldn't go over to the adjacent tooth. So you could take a brush and actually wipe away that excess. You can see me trying to inject enough that it goes all the way down here. And once it flows out of that little porthole, then you're there and you can move on to the next tooth. So it is dual cure. If you wait long enough, this is going to begin setting up. So as you go, either you or your assistant, it would be wise, and I learned this the hard way, to use a brush and remove all that excess. It'll make for a whole lot less trimming when you do that. You could just as easily do this same technique with flowable composite and then light cure it. You could even do it with heated paste composite. So if you're trying to get the highest strength possible, then probably heating some paste composite would be an excellent option here. But you would still do the case the exact same way. All right, so we're going to cure all of this. And then once it's all been cured, your stent is going to be locked on there, or at least mine was, because again, I did not remove that excess overflow. So I'm having to adjust that off. And I kind of tore up the stent as I was removing all this. But when you do eventually get it off, you're going to have to clean up the embrasures. You're going to have to clean up your margins a little bit. But the hardest part is usually the contacts, and those should be open. Those should be able to be opened up with just like your Contact Easy or your metal strips. Okay. And you'll have some little sprues here that have to be taken off as well. So you're seeing me remove that with that microcopy diamond. All right. Jumping forward, that same little cone-shaped diamond is excellent for going at the gingival margin. And so what I try to do is just stick the tip barely subgingival and not beat up the gingiva, but just go through there and break off any flash with that burr. Here you see the other egg-shaped diamond, getting rid of those occlusal sprue holes. And then the last thing is going to be, check with floss, and any jagged areas you're going to need to use your interproximal strips to smooth those up and make this where it's smooth and flossing easily. And once that's done, you're pretty much finished with it. You can use a curved blade to do some trimming, but note the contacts here. I am able to get a good contact. It's popping through there despite the fact that there was a mylar present. I've had people ask me, how is it that you could possibly have that mylar present and not have an open contact? And I guess technically it might be open, but the reality is that it's such a big, long and broad contact that they really floss very well. So it's not going to be like what you would think of as a normal open contact. These are going to be very stable. And then once you've done all this, remember, you're going to have to equilibrate it in the mouth. There's always a little wiggle room and room for error in these techniques with these stents. So equilibrate them, use your leaf gauge, check them out, make sure that you get them down into where that bite is the same in centric as it is in MI. And here was the final result. Again, the downfall of dual cure materials in general is they're not as aesthetic. And so you might have noticed there that that didn't have quite as much of a shine on it as the other composites that I've shown. All right, so, and I just threw this one in. This is just a couple slides. This is, I used to call this the poor man's CEREC because it was my method. If a patient needed a crown, they couldn't afford it, and I didn't want to spend a lot of time, but they needed a solution, this is something I would do for them, and they really worked very well. So consider if you had a tooth like this. This tooth has a bunch of cracks in it. It's got severe perio. If you submitted this to insurance, there's no way they'd approve your treatment plan for a crown. It's unopposed. There's not a tooth opposing it. So it's kind of like, is it really worth that much? It's got caries on it. It's sensitive, and the patient has no money. So it's kind of like the perfect storm, but she wants to keep it, right? So what the heck do you do with that? Well, what I started doing was basically making them a crown, but making it almost as if you would a temporary, but I would use a long-term composite resin, okay? And so since this tooth was in good shape, as far as the overall shape of it, we just took a triple tray impression of it preoperatively, and then I went ahead and prepped it, okay? So this is not as non-aggressive as the others, but this tooth needs a crown. I mean, due to all the issues it's got, it just doesn't justify the cost of a crown. So what we can do once we've prepped this, and I do try to prep it with a significant margin that's very readable, and I try to keep that supragingival wherever possible. But once we do that, just like I would if I was going to make a temporary crown after I've finished my prep, I'm going to inject material in here, but instead of it being bisacryl or acrylic, I'm going to use a dual cured composite. Okay. So we load this with composite, we put it on the tooth, and we just have them bite back into it until it fully sets. Well, actually, not until it fully sets. You'll have to play with the timing on this. Just like when you make a temporary, you want to pull it when it's mostly set, but still has a little gumminess so it doesn't stay adhered to the tooth. And then with that out of the mouth, I'm just going to trim up these edges. I'm going to clean it up really good. And the reason I like that to make a more aggressive margin is so that it's very readable and I don't leave any flash or excess. And then what I'll do with this crown, this is a crown made out of long-term definitive composite. And all I'm going to do is now sandblast the internal of that and the tooth, and then use etchant, bonding agent, and a resin cement. And I'm going to cement this. Okay. It's the exact same shape as her original tooth, exact same occlusion, exact same contours. And you can see how nicely adapted we got this. Now she's bleeding because I've been adjusting on this, but that is a perfectly flush margin. I mean, an explorer can't even feel that. We've got good contacts. And it's a way to make a crown for a patient in 15 minutes. Obviously, don't go bill insurance for a ceramic crown on this. The way I build it, I don't know how you would bill it, honestly. A temporary, or you could call it a 4 or 5 surface composite, because it is that. You've done a little bit indirect technique to make it happen. But I mean, if you bill insurance for a 5 surface direct composite, when you actually did it direct, I mean, they're the ones winning on that. So I would think that that's a legitimate way to build these things. But, you know, it's a simple technique. And I actually got to see several of these things on recalls. So this is one that we did. Guy had perio again. It's unopposed. It doesn't really justify the crown, and he couldn't afford it anyway. So we did one of these, and this is 2-year recall. It looks just like the day we placed it. And margins are still nice. There's not been bone loss. That little gap is actually cement, but I mean, this turned out really well. You know, the worry would be that this is not quite as precise and you might have some gaps in the margin. That's why I use the resin cement, because that's going to set up and be resin, and it's going to fill all of those little potential gaps. I mean, think back to the days of the early Cerax. I mean, everything had open gaps everywhere, but you filled them with your resin cement, right? Well, this is no different. Okay, so this is that same 2-year recall. Again, very flush here. It holds up excellent. And so you could hypothetically do a full mouth rehab using this technique, right? You could just do individual composite fabricated crowns and then bond them onto the teeth. And that would be another acceptable way of doing a composite rehab. Definitely more aggressive though. So I would do this when just ideal treatment isn't feasible. Cracked teeth that I want to evaluate before putting the money into a real crown. Patient doesn't have money, they're unopposed, perio, long-term prognosis is bad. I had a lot of patients that they would get endo and then they couldn't afford the crown. Well, if you don't get a crown on a posterior tooth after endo, it's not going to last. And so oftentimes we would do them one of these and they would hold up great, and they would keep that endo in good condition until they could get the definitive crown. And then again, they're good for staged treatment plans. You could build a person's full mouth rehab just like this, and then gradually convert them over to ceramic or whatever type of crown you want, zirconia, or a long-term temporary. So these work very well, and I did quite a few of them. So hopefully I've given you a whole bunch of ideas of different ways you could approach these cases. And I'm sure there's a dozen others I have not shown, but that's why YouTube's great. I'm sure you can go and find those elsewhere. So appreciate you tuning in and watching this. If you have questions or want to ask me about, you know, other courses or things, you can email me. This is my email. This is my website, which, you know, not a lot going on right there, but generally I would post courses on my website here at coryglenn.org. Since we're not doing any live patient courses right now, it's empty, but hopefully we'll see that turnaround soon. And then most things that I've done in my career, or at least a lot of them, are on my YouTube channel. There's tons of tutorials. So if you go on YouTube, my channel is just my name, Cory Glenn. And I believe that is it. Michael, are there any other questions before we wrap it up?
Yeah, there are a bunch of questions, but maybe before you start taking those, I'm just gonna repeat some of the things I mentioned at the beginning. First of all, we have 2 webinars scheduled for tomorrow. Cory's presenting again, and we have one in the morning at 9:30 that's going to be given by Robert Mickley. So if you haven't yet registered, check out blueskyplan.com/webinars 2020. And in addition to that, just to mention again that if you're watching live, we'll be sending you the CE directly to your email. And if you're watching the recording, then you could complete the 10-question multiple choice test to get the CE credit. And that's for other past recorded webinars as well. Okay.
All right. So how do you close the contacts? I'm guessing that question was referring to where I left that Mylar in place. But like I was mentioning, even though I guess theoretically it's at least an open contact as wide as a Mylar sheet, which is tiny, but the reality is the contacts are so big and broad that they still pop floss, they don't pack food and everything. So I would find that unnecessary. But, you know, listen, if something screws up and you do have an open contact, you buzz it out, you throw a greater curve band on it, and you restore it like a class 3, and now you've got your contact back. Is there a digital version of the COIS table? And in fact, there is. If I was to go to my YouTube channel, I actually just created one not long ago. So if you go under videos, it's not truly the COIS thing, but it's the same principles. And what I created was basically a hinge articulator that can be used in Mesh Mixer, okay? So it does allow you to align the models to the little COIS plate, or you could even make your own little plate of some kind. But the problem in Mesh Mixer, and even currently right now in Blue Skies, we didn't have the ability to open in a true hinge like an articulator would if you were trying to open the bite. And so this was just a digital hack that allowed us to do that. Essentially, I lined it up to an articulator, and this is a Bonwell triangle. And so we know that it's, I think, 105 millimeters from the joints up to the anterior teeth right here. And so this allows you to position your models at the front end of this triangle. There is a plate here associated with it that you can stick those on. But what it allows you to do is then take this, find it, and create a hinge up here at the back of this. So just like you would in a typical actual articulator, you can actually rotate the lower arch and have it hinge from back here so that it's more like a true anatomic movement. It's at least the digital equivalent of a semi-adjustable articulator. Okay, so you can see here, I've opened the bite. We won't watch this whole video, but it's on my channel. Check that out. That's a nice option. You could either make one yourself, or I have that for sale, I think on Dentistry downloaded for very cheap. Next one, in the past, the injectable flowable composite is thought to have less strength compared to regular packable. That is true. Do we worry about the duration in full arch construction? Potentially. I've had a couple of patients that would break some dual cure stuff, and I've had some patients that it held up beautifully in. But if you're concerned about it, then use a paste composite. Pretty much everything I've shown here, except for the cases where you had to have dual cure because you couldn't get light to it, but every other technique, you could just as easily use a paste composite, and it'll work especially well if you'll heat that composite. So they make composite heaters, and it more or less turns your paste composite into the viscosity of flowable. And then you could do all the same stuff with a typical paste composite. Okay, so that should take care of that if you wanted to go that route. Video's not been playing. Yeah, sorry. I suck, sorry. Yep, working now. Okay, so it only took about 40 minutes of y'all watching a blank screen. So that was good news. Have you tried the Mylar strips placed through cuts in the stent, yeah, so that I showed a couple of cases with that, and it does work well. Again, my only advice that I didn't do in those cases was I would suggest you or your assistant one taking a brush and wiping away any excess that extrudes out that proximal by the mylar and out of your little injection ports, because it'll make your cleanup a lot easier. How do you bill for the composite crown? Yeah, I don't know the answer to that, frankly, but I would be inclined to just call it a 4 or 5 surface composite. And that is true. It's been indirectly made, but I wouldn't feel right about billing insurance for an indirect composite restoration using that method. I think the code, when it's referring to an indirect composite, assumes that you're probably talking about a lab-made restoration. So that would be a little questionable ethically for me. I would just bill it as a 5-surface composite, and hopefully everyone's happy. It's cheap for the insurance. It's quick for you. Patient gets what they need. So believe that is the last of the questions, unless you see others.
No, I think that takes care of it.
Cool. All right, well, thanks for watching, and let me know if I can help you further. And if you're interested in full arch implants and bone reduction guides and drilling guides and prosthetics, that'll be tomorrow's webinar. So hopefully see you again.
Cory, thanks so much as always, and we'll be back tomorrow.
Okay, thanks, Michael. We'll see you.
Okay, thanks everybody. Thanks for attending.